Thank you. All right, good morning. Today is class 6. So there's only 8 classes in the session, so we have 2 to go after today. But Monday is our last skills day. So we're almost done with the skills. We have 3 to learn today plus blood pressure because I didn't get to that before. And then on Monday, you'll have 3 skills to learn, and that will finish all the skills up. So we're kind of getting on to the easy part of the class now because there's not much to learn. You guys have mastered all the principles. You know what needs to be done or how to do the skills. You know to consult the care plan. You know the basics. So all we're going to do is take those principles and kind of rearrange them, put them in a different order, and create some new skills out of them. So this is kind of the easier part of the class. All right. So before we get started today, you guys had chapter 7 to read between last class and this class. And the test on page 187, and then grade it. So when I call your name, if you can tell me your score or how many you missed. Akayla? Felicity? Jamie?
100.
Thank you. Peyton?
95.
Thank you. Gloria?
90.
Gloria, do you have 6 for me? I'm not sure how I missed it. I'm sorry. It'll be 80? Okay. Kenley?
100.
Thank you. Zarina? Melissa? Tasha?
100.
Thank you. Nancy? Jasmine? Jose? Alani?
95.
Thank you. Amelia?
85.
Amelia, do you have 5 and 6 for me?
I don't have 5, but I have 6.
Okay.
6 is going to be 70.
Thank you. Isabella? Does anybody have any questions on what you missed? Good morning. Anybody have any questions on what you missed? On any of the chapters? Everybody good? Okay. So before we went live, you had a question. I know I just, I'll give you a second. If you want to say your question out loud, I will answer it. I know I pick on you right as you take a bite. I'm sorry.
No, that's okay. When we go to take our skills test and we don't grab enough supplies, like towels or anything,
Right.
what happens?
Okay. So the question for those of you at home are, during the test, if you don't take the right amount of supplies, what happens? So there is no graded checkpoint on the exam for supplies. It doesn't say got the right amount of washcloths or obtained the right supply. Actually, the checklist doesn't mention supplies at all, except that you can't put soiled linens directly on the table. They have to be on a barrier, and you can't put anything on the floor. You also can't hold anything against your uniform. That is the only thing that the checklist grades as far as supplies. So the answer to the question is, it doesn't matter. If you realize that you didn't take enough washcloths, you can go and get washcloths at any time, but that's right. The supply shelf is clean. And remember our what we learned early in the program, we have to have clean hands to get our clean supplies. You guys remember that? So that's going to apply here. If you forget supplies, no problem. You can get them at any point, but you just have to make sure you have clean hands to get them. So you're going to stop what you're doing, go wash your hands, and then get the supplies that you need. Good. Good. So the principles that we learned really do apply universally. Every situation you find yourself in, one of these principles will apply to it. So as long as you remember you can't touch your supplies until your hands are clean, you're good. Any other questions? Okay.
One is, are we going to be learning about philosophy bag care?
Your book is going to talk about it.
Yeah, I was
Um,
reading about it. That's why I was asking.
yeah, it's not something that is on the state exam.
Okay.
And one of the reasons for that is that colostomy care has to be individualized. There is no one size fits all rule like with washing. You know, if we're going to wash something, we have rules to follow. Care plan will adapt it. But those rules are pretty universal. You know, they apply unless a care plan says otherwise, they apply to everybody. With any type of ostomy, whether it's a colostomy, a ileostomy, a nephrostomy, that term ostomy just means a tube exiting the body. Or actually, it technically it means the hole the tube is in, but you kind of get the idea. Okay. All of those are individual based on the patient. There are no universal rules. Does that make sense? Right? We can only teach you things in class that are universally applied. Anything else has to be patient specific, and ostomies are one of those. With ostomy care, it really depends on where the ostomy is as to how we're going to care for it. So that's going to require training for that specific patient by the nurse. Right. Right. Some ostomies require skin prep, right? So we have to use some sort of a barrier. Sometimes it's an ostomy powder. Sometimes there's barrier creams that we use after the wafer is put in place. Good morning. It's very, very patient specific. So it's not something that we're really going to cover in class beyond the reading. That's just basic what an ostomy is, you know. But ostomies are often managed by the patient. They really are. There are some situations where CNAs are going to deal with ostomies, but in a very real sense, patients are usually encouraged strongly to manage their own ostomies. And again, that's where you get that care plan involvement, right? Because every patient's going to be different. Now, there are situations where patients can't manage their own ostomies, and then that would be, you know, certainly something that they could delegate to us. Okay. So you said you had several questions.
Yes. My next one would be about the medical abbreviations. If I remember correctly, you said to memorize the highlighted ones. So then I got over to the try it yourself page, and there was a couple that were not on the highlighted, such as the P that has the line on top.
Right.
So,
You're not going to have that on the state exam.
okay.
So that,
Only the highlighted ones are on the state exam.
and honestly, those probably aren't even going to be on the state exam. I want you to know them because you're going to need them for work. The try it yourself page was to show you kind of how those medical abbreviations might be used. Yeah, it might be used in a clinical setting. So it gets you a little bit more familiar with it. It's a great way of being able to take notes in healthcare because we shorten everything. We shorten everything. Half of your medical abbreviations are abbreviated English. The other half are abbreviated Latin. There's no rhyme or reason to it. You just have to memorize them. But one of the ones that gets messed up quite often are the ones at the very top of the first column, the frequency section. So if you look on page 132, these,
A lot of them, they just don't make any sense.
right.
So it's
And
not
that's because you're,
out of bed. OOB.
yeah, that one makes sense, right?
It does.
So here's where it's abbreviated Latin. So Q, it stands for, and please, those of you who are attending virtually, do not yell at me in the comments. I know my Latin is crap, but we're going to go with it. Okay. So Q stands for the word quake, which I know I'm not pronouncing exactly right, but that means every. It's like us saying every. Okay. So Q, if it stands for every, QD would be every day, although it's actually the Latin word for day, which happens to start with D too, thankfully. Okay. So QD is every day. Q2H would be every 2 hours. Okay. What you're not going to see anymore is QOD. We don't use that one anymore. Every other day. And the reason we don't use that anymore is that O can often be overlooked, especially with doctors' handwriting, can look like a period if they're in a rush. And now we go from every day to every other day or vice versa, and it can be lead to medical errors. So you don't see that one as much. Wherever you go to work, doesn't matter where it is, pick a place. Hospital, rehab, nursing home, home care, mental health, walk-in clinic, doesn't matter. Wherever you go to work, part of that policy and procedure manual is going to be a list of approved abbreviations for that facility. They have to. That is a requirement that they have to publish approved abbreviations. So during your orientation period, no matter where you work, you get an orientation period. That's something that you probably would want to pay some pretty close attention to. Okay, good. So let's look a little bit further down that list. So we know that Q means every, but then we get to the IDs, the BID, the TID, and those are also abbreviated Latin, and they don't really make sense to people. How does BID stand for twice a day? Well, B stands for bi. How many wheels does a bicycle have? 2. So bi means 2 times a day. T stands for tri. How many wheels does a tricycle have? 3. So TID is 3 times a day. And then you get down to QHS. And what in the heck is that? Well, again, Q is for every. HS is orosomny, or how they say bedtime. Like, I'm going to bed, I'm tired. HS would be, orosomny would be, it's when time for me to go to sleep now. So QHS is bedtime. QAM. Now we think AM is English. It's not. English, or AM is not English. PM is not English. We've adapted it to our own use, but it's actually Latin. Ante-meridian, which is before noon. Post-meridian, after noon. Meridian is noon. Middle. Make sense? Good. You're not going to have these on the state exam. The only ones that you probably will see are CNA. We do need to know what a CNA is. RN, we need to know what that is. NPO, because it directly relates to what we do. And out of bed, bedside commode, things that relate to the activities we're going to be doing with the patient. You don't need to know medical terminology. You don't need to know congestive heart failure, what it is, how it works. That's not the role of a CNA. We need to know enough to be able to follow the care plan. Good. And a lot of people, this is where a lot of people fail the written exam, because they spend all of their time studying those types of things. And that's not what's on the exam. When I was a brand new instructor, brand new, like my first class, that's what I was focusing on. I'm going to teach you medical terminology. I'm going to teach you body systems. I'm going to teach you all the nursey stuff. and none of it was on the exam. My students didn't do all that well. So that's what pushed me to learn what's on the exam, because I was trying to create mini nurses. It's not what a CNA is. A CNA is not a mini nurse. You're an assistant. Your knowledge is limited. Your abilities are expanded. It's what you do that counts, not what you know. Make sense? Okay. All right. So very brief review. This is our last review. This is it. How do we know what to do with each patient? Care plan. We're going to follow the care plan, the whole care plan, and nothing but the care plan. While we do that, we're going to make observations. And who do we report the observations to? The nurse. Absolutely. Remember, our policy and procedure manual is our blanket instruction manual for everybody. The care plan is going to refine that specific to this patient. It's our instruction manual for this one. Okay. Every skill starts with an opening. Every opening starts with a knock. And then we're going to greet our resident, address them by name. We're going to tell them our name and title. We're going to get permission. We're going to close the curtain, wash our hands, and then get our supplies. Our cardinal rule here, do not touch the patient until your hands are clean. Once we've done our opening and gotten permission, then we need to start thinking about supplies. And the very first supply we're going to think about is this one, gloves. We're going to use gloves if it's possible that we might touch body fluids, personal skin, or non-intact skin. If we decide to wear gloves, the first thing they should touch is the patient. And then once you've touched the patient, you got to pay attention to the areas that you're touching, because we don't want to move all of those patients' cooties into a whole bunch of new places. Okay. Now, if we need supplies, we're going to need a place to put them, and that's our barrier. You cannot put supplies directly on this table. It is not clean. So we're going to get a barrier first, put it on the table, and then get our clean supplies. Remember that you cannot get supplies until your hands are clean. That's a principle. It doesn't matter when during the skill we're using it. If we're getting supplies, if we're going in to our supply shelf, we have to have clean hands to do that. Okay, good. Sometimes a supply that we need will be a privacy blanket. We're going to use a privacy blanket anytime the patient is uncovered or undressed. If you see a patient's knobby knees, you should automatically think Miss Patty will be displeased, and go get them a privacy blanket.
I thought about that when I was at my mom's nursing home. I was walking by and I see knobby knees. I'm like, he needs a blanket.
That's correct. That is correct. Yep. Yep. I know. And they're such silly rules, aren't they? Right? They're such silly rules, but they'll stay in your brain. Like 20 years from now, you're going to remember that.
Are there situations where they don't need it? Like where they're prescribed to be colder, trying to get colder?
You would go by your care plan.
Okay. I just assume as a person who's like, you're not a nurse working at the facility, you're just walking by as a civilian, and then you see that and you make that assumption. But could it be right to counter that assumption with saying that they might have orders to leave their knees knobby?
I can't think of any off the top of my head, but yes, I'm sure there is. Okay. And that's why we have the care plan, because there's a whole bunch of, situations that I'm just not familiar. Well, and I can think of one actually. If the patient has a fever of like 102, putting a blanket on them might not be the best course of action, because we're holding in that body heat, which can actually elevate the temperature a little bit more. Now, if they're having chills, they're going to want that blanket. I get it. But as a nurse, I may actually have, keep the patient covered with a light sheet, because I don't want to inflate that temperature. I don't, yeah. And it's all about the patient's exposure, right? They're laying down. And you have to think about how vulnerable you are when you're laying down. It's all about vulnerability. Okay. So if you've got somebody that's laying down, they're already vulnerable. Now take their clothes away. How are they feeling?
Exposed and probably cold.
Okay. So now take that sheet away. This is a psychological thing. It does have to do with temperature. Yes, it does. But it also has to do with psychology. We are strangers and they're not able to defend themselves at the moment. That blanket, it's not a magic suit of armor, but it does help give them at least some layer of protection. And yeah, we might have somebody that's like, hey, you've seen it all. I don't care. You know, I'm 90 years old. If you haven't seen it by now, good luck for you. You know, I mean, they might actually feel that way, and that's fine. I have no problem with the patient making that decision. Should I make that decision for them? That's the difference. Okay. Does that make sense?
I was thinking more like if I'm on the job, there was two things that was mentioned. In previous class, you mentioned that if the bed needs to be made, you can do it. Go do it. That's what I'm thinking in my head. So now with the
Right.
nice thing is if I'm on the job, whatever, walking to a different place, and I notice that it's a right to assume to go get them done.
So we shouldn't really be doing anything with anybody unless we're assigned to care for them, only because we don't know their care plan.
Yeah.
We don't know what their care plan says. Now, there's two situations, and I'm going to get to your question in just a second. There's two very specific situations where that rule does not apply. One is safety. If you see a patient falling out of bed, whether they're your patient or not, we shouldn't just stand there and go, huh. Yeah. I mean, it's, we got to address safety. You know, if you see a patient walking down the hallway and they drop down and they start having a seizure, we're not just going to be like, huh, interesting. All right, got to go. Right. So safety becomes a very big issue. We don't need the care plan for safety. Safety is safety. Now, the other situation where you will intervene without knowing the care plan is when the call light goes off. Because every call light could indicate safety. So we would go in and if you see a call light, it needs to be answered. Whether it's your patient or not, it needs to be answered. You need to stick your head in and go, everything okay in here? Chances are it's probably, I got to pee. I need some water. I'm cold. Right? Something very simple. Well, we can't take care of any of that because we don't know. What's that? Yeah, we can take care of that. Right. But we don't know. Can they get to the bathroom? Do they use a bedpan? You know, is it a catheter? We don't know what their care plan is. We can't help them to the bathroom. Well, no, because you haven't gotten a report on that. Not your patient. You're just walking down the hallway, right? You don't know this guy at all. Nope. Care plans are going to be given to you in report when you start your shift. So you don't know, right? But that call light could also indicate a problem. I'm having chest pain. Do you know the worst place to have a heart attack? You know where the worst place is to have a heart attack? The hospital. Yeah. That is the absolute worst place to have a heart attack because you're sitting in a bed and you're there for something else. That's what the team is focused on. That's something else. They're not focused on the fact that you could be having a cardiac event. They're focused on something else. Your surgery, your diabetes, your illness, whatever it is that brought you to the hospital. You hit the call light and it could take them 30, 45 minutes before they even get into the room to find out why you hit that call light. That is the worst place to have a cardiac event because as workers, we get complacent. Every single call light is, I have to pee. I want a drink of water. I'm cold, right? Every call light. You do that for years. You work in that hospital for years, and every call light is one of those three, right? Every single call light. It desensitizes you. So you start ignoring the call lights until you can get around to it. But those call lights really are also there for, I'm having chest pain and somebody should probably come help me. Does that make sense? So call lights, if you see one, you should stick your head in and just make sure it's not an emergency. And then let somebody know, hey, Mr. Jones's call light's going off. No emergency, but he needs some water. You know, he's hungry. He's got to pee. Whatever the case may be, right? But those are the two situations where I don't care what the care plan says. If it's safety or if it's call light, any staff member can address it and should address it. Good? Make sense? Okay. But if we walk by and see knobby knees, that's not our patient, not our issue. Keep walking, because it's not, we don't know their care plan. We don't know their specific situation. Yeah, you're going to see knobby knees now and again because sometimes people have external fixation. It's like the scaffolding that's holding the legs together, right? Well, they're not going to be under the sheet. Yeah, you might have a woman in her 50s that's currently going through some menopause issues, and life is hot and sheets are not involved. Okay, so there's all kinds of different scenarios and situations. We don't know them if we don't know the care plan, so not our business.
My question is basically, so patients or residents can request not to have a blanket on it and then on their legs, and then it'd be fine if they're not knees wrapped.
Yeah, but Miss Patty doesn't like knobby knees.
You would like put pants on them or something?
Yeah, they're going to have to convince me pretty hard. Yeah, they're going to have to convince me pretty hard. And the reason is, and a lot of times these patients, they think they're saving you time, right? They don't want to take any more of your time than they have to. They do. So, hey, you've seen it all. I don't need a blanket. It's fine. I am more comfortable if you have a blanket. That's all I say. I'm more comfortable if you have a blanket. And as long as they think they're doing me a favor, they'll go, oh, okay, that's fine then. You also have to understand that that blanket is there to help protect you as well. Because anybody can accuse you of anything, right? If you're taking the steps you have available to you to take to minimize exposure, it helps frame accusations a little differently. There was, and I'll tell you this story, there was a female CNA, and this is probably 25, 30 years ago. This is a very long time ago. There was a female CNA who was working in a nursing home in a locked wing. So this was mainly dementia patients, but we did have 2 individuals in there that did not have dementia, but they did have advanced mental illness. Now, there were no places at the time, remember 25, 30 years ago, there were no residential mental health facilities in the community. So we had 2 mental health patients in the locked dementia unit. And we had a female CNA, and she was providing care. And one of the mental health patients was probably in her 40s, 50s, middle age, but had pretty severe mental illness and was, she did something called staff splitting, where she would really, really, really suck up to you and be really mean to you and talk to you about her. And the whole goal of it was to get you guys fighting for her entertainment. It's called staff splitting. It's very common in mental health settings, very common. You have to be really careful about it. If a mental health patient makes you their best friend, there's something in it for them. And you have to be aware of that. Okay. So this patient accused the female CNA of sexual misconduct. Now, the staff knew the patient. The staff knew that this CNA was very diligent in making sure the patient was covered, providing privacy, encouraging modesty. We knew the situation, so we knew that this was a ploy, thankfully for the CNA. But what if that CNA wasn't conscientious? What if the CNA just walked in and pulled the sheet down and exposed the patient because they're mentally ill and who cares? Right? Would we have looked at that accusation a little different? That blanket helps protect you. Do you guys see that? By taking the steps to preserve modesty, it can help establish those patterns that keep you from being accused or accusations being taken your habits are going to define what kind of CNA you are.
Residents will always snitch on you too. They'll say, well, they do it for me. They do it for me.
They
So
do.
they'll always snitch on you.
Absolutely. Absolutely. And they'll lie.
They will.
They'll lie. They'll tell you somebody else is doing something for them to get you to do it. Yeah. And diabetic patients are pretty bad about this. Diabetic patients will say, oh, well, Amanda goes and gets me M&Ms out of the vending machine. Why aren't you getting me M&Ms out of the vending machine? Is Amanda a better CNA than you are?
Everybody leaves my meds in my room.
Yep.
Don't watch me take them.
Yeah. And that's fine for everybody else, but I am me. And I am not everybody else, and this is the way I do it. So take your pills. No M&Ms. So we do have to understand that the habits that we cultivate from the very beginning are going to define us as a CNA. And that's one of the reasons that I teach you to do a lot of the things that I'm teaching you to do, because I want you to develop that reputation as a good CNA, not one that cuts corners, not one that puts your patient at risk. Make sense? Okay. This class would go a whole lot quicker if I didn't focus on these things. If I just told you wear gloves for everything, if I just told you patients don't need to be covered, just do what you need to do. If I told you that patients in healthcare have to do everything we tell them to, and we do everything the same way with everybody, I mean, I could do this class in like a 4-hour day. And you might get lucky and pass the test. But the problem is that once you get out there and you start working, you're not going to be effective. You're going to feel like I didn't learn what I need. I'm completely unprepared here. And you're already going to feel that way a little bit because there's always a transition from school to work. And it's always a rough transition. But I don't want you to feel completely and totally unprepared. That's why I take the time to give you all of this information. And that's going to make you a much more effective CNA. And those of you who go on, these are the same principles we use in nursing and in all aspects of healthcare. So it ultimately makes you a better provider. Okay. Make sense? So as far as knobby knees go, which is what started this, I'm pretty insistent on this when I'm working with patients. And part of the reason is what you guys just talked about, right? Patients will tell on you. But it kind of goes the other way. We train patients what to expect by the way we treat them. And if the last 3 weeks of CNAs never used a privacy blanket, and here I come along and I'm using a privacy blanket. They're going to say, that's weird, odd. Nobody else has used that. I don't need that. I'm good. They've been doing this for 3 weeks without it. So what we've trained that patient to do is accept a substandard level of care. That's what we trained them to do. They're paying for care, but we're telling them, oh, it's okay if you don't get the care you're paying for, because I don't do it that way. And that's just not, that's not a good thing to do. It's just not good. Do you want somebody to do that to you when you're the patient? To train you to accept a substandard level of care? No. So that's where there's a lot of psychology that goes into this, right? Especially the privacy blanket one, because it really is about the comfort of the patient. Psychology. Yes, it does keep them warm. There is a physical component to it, but that's not really why I'm doing it. I'm doing it for their peace of mind, their dignity, their psychology. So yeah, I'm pretty militant about it. And I'll tell the patient, oh, I'm so sorry that nobody has done this before. Let's try it with the blanket and see if you feel any more secure. And then you can decide what you want from there. I'm going to put the power back in the patient's hands. It's not a decision I need to make for anybody else. Me personally, if I'm laying in that bed, please use a privacy blanket. I don't want my dangly bits all over for everybody to see. They're mine. I should have the right to decide who sees them and who doesn't. That's how I look at it. The test isn't going to grade you on it. If you decide not to use a privacy blanket for the test, that's fine. There are a few skills that do require the patient remains covered, like bedpan, which we're going to learn on Monday, but you can use a sheet for that. Turning a patient onto their side, you can keep them covered with a sheet. It's just hard to get their, the pillow in between their legs because the sheet's in the way. But you can untuck it and then retuck it. That's fine. You're not graded on using a privacy blanket, but I want you to have a higher level of performance.
I think it's good practice overall.
It's a basic nursing principle. And that's why you need to know it.
In like ALS, can you just use like one of their blankets? as a
Absolutely.
blanket?
Yeah. If you're in a private room with a patient and it's just you and them and the door is closed, they may say, I don't need the blanket. And you may say, okay, that's fine, because they're comfortable with you.
Yeah.
And that's a decision that the patient can make. I'm not making it. It's a decision the patient will make.
Just at least give them the choice of privacy.
Absolutely. And today they might feel some kind of way. Right? We are not exactly the same as we were yesterday. Everybody has vacillations in their thought process, their mood, their, everything changes with you. You guys all get mood swings. Everybody gets mood swings, right? So if they've never asked for a privacy or, never accepted a privacy, they don't ask, but if they've never accepted a privacy blanket before and you offer it today, they might say yes because they're feeling some kind of way. And that's okay. But that's an observation. What do you think I should do with that observation? Tell the nurse, because I don't know what happened to that patient overnight. And that might be something that we need to look into a little closer.
Just one more question about privacy blanket. What is it exactly? Can we tell by right away? Is it labeled privacy blanket? Is this a smaller than a blanket?
Anything can be a private. You can use a towel as a privacy blanket. You can use another, the sheet. Anything that covers the patient. Okay. Yeah, it covers the important bits. Okay. Anything can be a privacy blanket. Don't get hung up on the name. But for the test, we're going to use this. This is a privacy blanket. It's a blanket. Yeah. If you've ever been into the ER,
Oh, they're all heated.
yeah, they've got blanket warmers. They are awesome. Yeah, that's what this is. They get softer the more they're washed. You wash this thing like 50 times and it becomes butter soft. It's awesome. But this is just, it's just a blanket. It's just a blanket. In the practice kits, we have fleece blankets that we give you for privacy blankets. That works too. Anything that covers the patient can be a privacy blanket. But for the test, they use this because this is what we use mostly in a clinical setting.
Will we have the chance to practice?
I'm hoping to give you guys some practice time. You're not going to get any today. Today is supposed to be a practice day for you. You're supposed to have about 45 minutes at the end of class today. But unfortunately, I ran a little bit long and we didn't get to blood pressure. So I've got to put blood pressure into today, which got rid of your practice time. You will have a little bit of practice time on Monday. Wednesday, we graduate. The following week, Monday and Wednesday, by appointment, you can schedule with Jake to come in and practice during those class hours, 9 to 1, on Monday and Wednesday, the week after graduation, to come in and practice. But you have to schedule with Jake and you have to show up because I'm tying up his time because he has to sit here. So I just don't want to get into a situation where somebody says, yeah, I'm coming to, and then he's sitting here for 4 hours with nothing to do. So he gets bored and I have to pay him. Okay. I want to make sure he's productive.
I have a question about the scheduling the test for the exam. When do we have to wait until we graduate to do it, or we could have been? Okay.
You should already.
Do it? Okay.
Yep. So the first thing you need to do is your background check.
Yeah.
And then 24 hours later,
Okay.
register for the exam. If you do that, like we did the last Wednesday was when we went over everything.
Yeah.
If you did the test registration over the weekend, you should be testing about a week or two after graduation, which is perfect timing. Long enough that you can practice, short enough that nothing goes out of your brain. The longer you wait, the further out your test date is going to be.
Yeah, how long after when it says pending approval? How long after?
7 to 10 days. So if you get let's go over the process real quick. We do our background check. 24 hours later, we register for the test. When you register for the test, within 3 days, you're going to get an email that says application status complete. You want to make sure it says complete. That means they found your background check in the clearinghouse. Your payment was confirmed. The packet is all together. We're good. You will then get one that says, at the bottom, it will say pending approval. Okay. What that means is they got everything together and then they pushed it over to the Board of Nursing. Now, this is a eyes-on event. It is not automated in any way. So when they send your packet over to the Board of Nursing, a human is actually sitting there looking at your application and your background check and making sure that you're not going to, steal grandma's meds. Okay. The email that you got from Prometric says pending approval. That means that they're sending all of that to the Board of Nursing for a person to do that. That whole process can take like 10 days for them to send it to the Board of Nursing and somebody to review it. Because obviously you're not the only one being reviewed.
Now, what happens if you don't get an email, but you can check the status and it says that?
If you did not get an email, check your spam folder.
Okay.
If you still did not get an email, you need to contact Prometric ASAP.
Okay.
Because if you did, that's how you're going to get your test date. If you didn't get the other emails, you're not going to know. They're going to issue your test date, send an email, and you're not going to know what that test date is. It'll come and go, and they don't give refunds. So you missed your test date.
Okay. 'Cause they gave me where I can log in and see everything, but that's about it.
you need to
Contact
you
them.
need to contact them. And the reason that you need to contact them is because they probably have your email address wrong.
Okay.
One letter off, one number off, .con instead of .com. There's a million typos that can occur in a email address. So if you haven't gotten an email, and it says it right on their website, if you do not get a confirmation when you submit your application within 3 to 5 days, you have to contact them because there's a problem. So make sure that you do that, because I don't want you to miss your test date.
So with the like background check, if they go in and like they can't find it, would they just deny it until you had your background check in? Or
Okay, so the way it works, and it's set up this way on purpose. So when you send your application into Prometric, okay, so there's 3 players here. Well, 4. There's you, there's Prometric, they're the coordinator. There's the clearinghouse, which is where your background check lives, and there's the Board of Nursing. So 4 players, right? So you send your application to Prometric. Prometric goes to the clearinghouse. If they don't find your background check, then that application status box is going to say incomplete. It never gets to the Board of Nursing. They don't deny you because they don't even know you exist yet. So in order for your application packet to get to the Board of Nursing, it has to have your background check.
if like they can't find your background check or something, do you have to repay to submit?
Well, it depends. If you just had it done and you use that code, the ORI number, EDOH0380Z, there's no reason for them not to find it.
So if I tried to like use my old background check and they couldn't find it, then I'd have to repay and submit another application.
Correct. And that's why on the Florida Board of Nursing website, it says everybody has to submit a new, brand new background check, because it's all about that ORI code. When you have your background check done through an employer uses a totally different code. They use an employment code and an OCA number for their facility. It goes into a different filing cabinet. So yeah, Prometric might possibly get lucky and be able to find it, but they're not going to look that hard, right? They want your background check in their filing cabinet where they expect it to be. And that's why the rule is that you have to have a brand new background check when you apply, because we're using that code. And I know some of you guys, especially if you're going into nursing school, right? You're getting ready. You got to get your background check in, and you've already paid $80 for that background check. It's a possibility they might be able to find it. It's worth a try, but it is going to delay you. You're going to pay one way or another. You're going to pay in time or money, because it's not coded for the right filing cabinet. They might find it, but it might take them some time. But if they don't, now you've got to go make your appointment. You've got to go get the background check done and wait for them to find it again. So that's your time payment.
For those of you that registered already, out of curiosity, where have you got your background check done at locally?
UPS.
Yeah, the UPS UPS store at Barclay is who we recommend. But you go to, did you get the flyer on the background check? Jacob, can you give her, hold that up for me. Okay, so that flyer, Jake's going to give it to you. DTIS back there. DTIS is the company that we recommend because it works well. It's well oiled. You will have no issues. So go online, register for your background check, attend the appointment. Once you
I have a background check already through my employer, home health aid, but I don't wanna risk it.
I don't either.
Yeah.
You said all that, cause I was just gonna wing it, like, you know, so I'm glad you asked that question.
So we have had people that took the chance and their background check was found.
Right.
Okay.
Well, mine's from 2022, when I first started being a home health aide. So.
They're good for 5 years.
See, mine was less than a month ago. They accepted mine.
But I went through DTIS too, but I'm gonna just do it again.
I didn't go through my employer. I just went through it like a fingerprinting place up here.
I went through assistant hands and they did the home health aid classes there. I got the certification, fingerprinted there, CPR classes there, all kind of one-stop shop situation. I don't know if it's big enough to, you know, as far as the background check goes, for it to go into the system that you're speaking of, or how that would work.
All I
I
can
think it's called Delta,
tell you,
is do this, to be honest.
there's a million scenarios.
Right.
I can't answer any of them. I have no control over, yeah, I have no control over any of that part of it. All I can tell you, and the reason that I'm being kind of anal about this is because 3 weeks ago, I was actually doing a training, okay, creating a training for CARES Link, which is I'm involved with, on the background check. So I started looking into it a little bit closer. Okay. If you go onto floridasnursing.gov and you look at their FAQs, frequently asked questions, this is a question they get all the time. I've already got a background check. Can I just use that? And it was unequivocal, stated on there. You must, according to the Florida statutes, you must submit a new background check for exams. That's what their website says, black and white. Now I know that there are people, you know, that have gotten away with it. You know, theirs was found and it was used and it cleared them, and that's great. If you want to take that chance, take the chance. But remember, if it doesn't work, it's going to cost you in time and money. So all I can tell you is what Florida's Board of Nursing website says. What you choose to do is up to you.
For the people who went to UPS to USPS,
UPS.
Yes.
how much did it cost?
I think was $89.
And how much was
If you register online with DTIS, if you actually do the online registration with them, it's $78.25.
When we did it online, it was $89.
Really?
Yeah.
Okay. Yeah, I'm going to have to look at that. But here's the thing, because you use a different ORI code.
No, I did it for her.
Oh, you did it for her?
Mhm. Yeah.
Just like a week ago?
We did it Monday?
last Thursday?
Yeah.
Okay, I'll have to look at that because I just did it like 6 weeks ago. Now everything has gone up. I mean, everything has gone up. I get it. But I just did it for the slideshow. Yeah, because I took the screenshots. I just did it 6 weeks ago. It was $78.25. So that's a heck of a jump. Yeah.
$89.35.
Wow. Okay. All right.
Did you say Barclay, the road?
Yeah, Barclay and Spring Hill Drive. You can do a walk-in, but it costs more. ORI is 0380. I'm sorry. Back up. EDOH 0380 Z as in zebra. Can you hold that up for me? This paper has it on there. Bolded.
How long do we have access to your online?
A year.
Oh, straight.
Sorry, I'm like on their website right now. Whenever I put the reasoning, it's gonna be for licensing, right?
Right.
Licensing?
Mhm. You don't have this paper?
I don't think so.
Jacob, can we get another one of those, please?
Thank you.
It tells you exactly what to put where. That's, yeah. Because their website can be a little confusing with everything that they ask. So that's why I made the cheat sheet for you. Any other questions? When you get done registering, let me know how much it is. All right. Linen roll. Going back to review now. Linen rolls. Linens can't touch your uniform. You have to have clean hands to get your linens. Don't snap or shake them. Clean rolls toward me, dirty rolls away. Nothing touches the floor. Not clean, not dirty. And anything you take and don't use has to be discarded. Don't leave it in the room for later. Patients must always be in the middle of the bed. You won't have side rails to keep them safe. Being in the middle of the bed is the best way to keep somebody safe. If you have to turn them in bed, scoot them towards you first so that they're in the middle of the bed after the roll. So scoot and roll. Always roll patient facing away from you so you remain behind, the patient's behind. Washing rules. We wash everything the same way. Doesn't matter what body part it is, it all gets washed the same way. First of all, don't add soap to your basin. You've got to have water for rinsing. You're going to use a paper towel to turn the faucet on and check the temperature with your wrist. It should feel warm, not hot, not cold. The evaluator will probably stick their finger in that water to verify temperature. So don't pretend. Get it warm enough for real use. Okay, because if you're using this water, like hand and nail care and foot care, you're doing that on a real person. Can you imagine for the test, somebody has to give you foot care and they go get ice cold water and then they expect you to put your foot in cold water? You're probably going to be a little resistant because it's cold. So that evaluator will put their finger in that water and just check and see, is this appropriate? Because that's a checkpoint. Okay. Your patient has to check the water too. We're going to use the leaves method for wet body opening. So eyes, nose, mouth, genitals, rectal area, wounds, rashes, sores, or incisions. We want to use a different area of the washcloth so that we're not cross-contaminating. Good. Change the water if it gets cold or soapy. Don't get your surface wet and warm up lotion before you put it on. Wipe off the excess. Cleaning the basin. Rinse it, dry it, store it. All you got to do for the test, rinse, dry, store.
If you are in the middle of cleaning them, your basin water gets soapy. You will say, "Excuse me, patient. I'm gonna go leave you alone for 2 minutes while I go redo this again." Is that okay to leave them alone for the 2 minutes?
Absolutely, as long as they're in the middle of the bed.
Okay.
As long as they're in the middle of the bed, because you're going to leave them alone when you leave the room anyway. So it doesn't matter as long as they're in the middle of the bed. Okay. But you're never putting soapy anything back in the basin.
No, just
Yeah.
not specifically soapy, but you know, something happened, you decide that you want to change the water.
Right. If this takes forever, if we're gabbing a little bit and I get off track and I put my hands in the basin and all of a sudden the water is a little chilly, I don't want to wash the patient with that. I'm definitely going to say, oh no, I'm so sorry. Let me go warm this water up real quick. Okay. And yeah, you can get off track pretty easy. For the test, try to streamline. All right. Oops, let's go back. I didn't do shoe rules. Remember that if the patient's feet hit the floor, we talk about their shoes. Slipper socks are not enough. They need shoes on to walk. If we're going to use a gait belt, we'll put it on over the patient's clothing. Don't know why that's a checkpoint. And you're going to check it with 4 fingers to make sure it's tight enough that it's not going to slip as you're lifting the patient up. Their feet should be flat on the floor before you lift them, and their hands should be on your shoulders. You're going to grab the back of the gait belt to lift on the count of 3. 1, 2, 3, lift. Make sure there's no obstacles in your way before you stand them up. After you stand them up, make sure they're not dizzy. Walk as far as care plan tells you to. But when you return them back to the chair, you've got to back up to make sure that their legs are touching the chair. They know it's there before you help them sit. Before you leave them, make sure they're seated properly in the chair, the hips against the back of the chair, that they're not kind of off to one side. Make sure they're seated properly. And then every skill ends the same way with closing. A lot of steps here. A lot of checkpoints we're getting checked off. So don't just get somebody sitting in a chair and say, okay, I'm done. You're not done. You've just missed about half of your checklist. So you want to make sure that the environment is clean and safe. So take a look around. Is it clean? Is the bed in the low position? Is your patient safe in their space? Are they sitting in the chair right, laying in the bed right? Are they safe? Bed height needs to be in the lowest position. Doesn't matter what happened during the skill, that bed needs to be in the lowest position when you're leaving. You want to make sure that they're comfortable, and they need to hear you say that word. Are you comfortable? We're also going to address preferences. Would you like a magazine? Would you like a crossword puzzle book? Something like that. Give them their call light. Open the curtain. A lot of C's there. Once you get all of that done, then you can wash your hands. Go clean your hands. Get rid of those cooties. If you're going to document, you'll do it after you wash your hands. But our very, very, very last action of everything we do is washing our hands. So we do that last after documenting as well. Okay?
Wash, document, wash.
Wash, document, wash. Good? Questions? All right, pulse. Pulse is a measurement of how many times the heart beat over 1 minute. We're going to count as long as care plan tells us to. We'll use the radial pulse located at the wrist. It's going to be at the top of the wrist. You're going to use your fingertips, not flat part, not your thumb. Put your fingers there, thumb on the back to hold consistent pressure. And you're going to count what you feel for as long as care plan says. Normal's between 60 and 100. That's what we're hoping to get. If it's more than 100, what do you do? Yeah, let the nurse know. If it's less than 60, what do you do? Tell the nurse. Absolutely. This is a documentation skill, so you have to document. Those rules apply. So we'll do our closing, wash our hands, document, and wash our hands again. In Florida, you may have to count with 2 evaluators if there are 2 there. Okay. Dressing a resident with a weak arm. The way you remember this is USA first. Undress strong arm first, and then we'll dress the weak arm first. That allows the garment to just fall right off that weak arm and slide right up that weak arm. Doesn't matter whether you start with the socks or the pants or the shirt. Nobody cares. Do it however you want to do it. But our care plan does tell us socks, pants, and shirts. So that's what we're going to put on them. Yeah, go ahead.
No, it's okay.
All right. Don't overextend or force movement. Adjust the clothing for neatness and appearance and put their call light in their stronger hand. We learn hand and nail care. This one's pretty easy. We soak the hand, we wash the hand, we rinse the hand, we dry the hand, we clean under the nails with an orange stick, wiping it off in between each nail. We file the rough edges with the emery board toward the center. We warm up the lotion and put it on, then wipe it off. That's hand and nail care. Making an occupied bed. We're making the bed a half at a time. So that bottom sheet, we're going to change with your patient on their side. So scoot toward me, roll away. So they're on their side in the middle of the bed, and we're going to loosen the sheet, the bottom sheet, on the side of the bed that we're standing on. We're going to roll it toward the patient because clean rolls toward me, dirty rolls away. Tuck it under the patient, put the clean sheet on and attach it. Roll that one toward us. Tuck it under the dirty. Roll the patient back on their back, go to the other side of the bed, do it all over again. Then you can put the top sheet on top of them because that's where the top sheet goes, is on top. Tuck the bottom of the top sheet under the mattress. Make your hospital corners, or at least get the corners under the mattress. Doesn't have to be pretty. And loosen it over the toes. Change the pillowcase last. You want to limit the amount of time your patient doesn't have a pillow. Opening of the pillowcase should face away from the door.
When we remove the pillow, are we allowed to elevate the bed up a little?
You can. Sure, you can if you want to. Doesn't have to.
Does clean corners translate to less wrinkles? That's really important.
So you want to try to minimize wrinkles under the patient. The tighter you roll that bottom sheet, the less wrinkles you have.
Just quick way to clean for yourself. You know, you make it and you see that corner's not clean. You can think, oh, that maybe wrinkles probably.
Yeah, so you want those corners tucked all the way around the mattress. Yeah. Side lying position. You're going to turn. Go ahead.
It's
$100
$100
now?
Yeah, it's a service fee of 40 and then a government fee of 60. And that's through DTI as well. Yeah.
Oh my
And so
gosh.
it's not me to make an account though. So it took me straight to like maybe it's because I didn't make an account. It took me straight to like inserting all of my information.
Huh. Okay.
Maybe because the government shut down, they have to pay someone to work off duty to do their.
Yeah, I don't know. Yeah, we're living in some very uncertain times at the moment. So
So the actual service bill is $40 and then the government fee is $60. It tells me what I'm paying.
wow. I'm a little concerned though that you didn't have to make an account.
I don't know. It just took me. I put in exactly this, and then it said like, and then you put the option like fingerprinting, the background checks and things. I can like go back and show you if you want after.
Yeah. Did you choose what the paper told you to choose? Okay. Oh, $100. It went up.
Yeah, we need to make an account.
Yeah, and in 6 weeks it went up that much.
So with fingerprinting, can I go anywhere and just, I can use that ORI number anywhere for fingerprints?
Yeah, can we shop around?
No, literally.
You don't have to. Okay, you don't have to use DTIS. I have no affiliation with them. They're not sponsored. I don't care where you go, but I would definitely go onto Prometric's website. Under their candidate resources, they have a list of approved vendors. You want to make sure that you're using an approved vendor, only because there are so many scam artists out there. And they'll tell you, oh yeah, we're definitely, we can be used for this, no problem. But then you pay them the money and the fingerprints aren't the right ones. They don't go to the right place. They didn't have the photo, because this is photo enabled. You have to have a photo with the fingerprints. And if, especially if you're going like through a mobile company, they may, to be just doing fingerprints, not the photo. So you've got to make sure. There's a lot of moving parts here, guys. So yes, you can shop around, absolutely. But I would definitely make sure that you're going through an approved vendor. Yeah. Yeah, as long as you follow those directions, because I'm the one that made that sheet. As long as you follow those directions, you should be fine. But yeah, it's everything's going up though. I mean, I'm surprised, but I'm not concerned. But yes, I will definitely be happy to look at that after. All right, so sideline position. If we have to turn a patient and they're not able to help, proper positioning is key. So you're going to scoot them towards you, furthest arm up, closest arm crosses, closest knee bent, furthest knee angled, turn them onto their side, pillow behind the back, pillow between the legs, pillow under the top arm, and adjust the one under the head. Call light goes in the bottom hand.
Is it possible for you? Where can we look at you scooting someone? Because my idea of scooting someone could be, I'm afraid, is different than someone. Than what would be the proper way of scooting someone? They're lying on the bed and you're
Every situation is going to be different.
okay.
Again, I can show you one way,
For
but
the test.
that's, well, for the test, you're going to ask the patient to scoot towards you.
Okay, and they're be able to. That's fine.
Right. So our care plan for this one says that they cannot roll. Doesn't say they can't scoot. It
Gotcha.
says they can't roll. So think of somebody who just had abdominal surgery. They can't flip themselves onto their side. Okay. But they can scoot their body over. But if I'm going to scoot somebody, if they can't scoot, then I'm going to use one of several methods. It depends on the needs of the patient. I might use a draw sheet, which is a sling, right? I might move them in segments, head and shoulders, torso, hips, legs. I might use a slide sheet, which is a super slippery sheet that helps move patients. There's lots of options there. It just depends on what my patient's needs are. If they have 3rd-degree burns on their back, I'm not sliding them anywhere. I'm going to leave half of their skin behind, right? So that would not be a good option. Draw sheet might be a much better option for them because it keeps everything together. But if the patient has compression fractures in their back, draw sheet is not a good option because that's just moving all of those bones around. So every situation is going to have a different solution.
Is there a general scoot that you generally put, like you put your hand on their shoulder and one on their knee and they pull towards you?
Again, it's going to depend on your patient.
Okay.
Yes, that
I'm
is
trying to imagine just doing it.
that is a method that you could use. Sure. So just like, the draw sheet is a method that we will use with some patients, and the slide sheet is a method that we would use. You would go by your care plan. But for the test, you just ask them to scoot. Good? All right, foot care, just like hand and nail care, a little bit lower. We're going to soak the foot, wash the foot, rinse the foot, dry the foot. The whole reason we're there is to look at the foot. Not doing anything with toenails here. We're not cleaning them. We are not filing them. We're not doing anything with toenails but looking at them. Warm up the lotion in your hands, put it on, and then wipe off the excess. Put their sock and their shoe back on, making sure that it fits correctly and that we've minimized wrinkles. Mouth care, you're brushing teeth. Make sure they're sitting upright. Protect their clothing with a towel. We're going to wet the toothbrush, put some toothpaste on it, brush what they've got. Let them rinse and spit as much as they need to. Leave their mouth dry. You got to dry them off. Use gloves for this because it's body fluids. Respirations. This is counting how many times your patient has breathed. The amount that we're going to count for is going to be determined by our care plan, but we always report it over 1 minute. Normal's between 12 and 20. Don't tell them you're counting their breathing. It alters their breathing. Range of motion. We've learned 3 range of motions. We're going to follow the recipe. Recipe is going to tell us what body part, what exercises, and how many repetitions. Support the extremities as you lift them. Don't overextend or force movement. You want to return all the way to the start position so that it's a full range of motion, and you're going to monitor for pain. Flexion extension is up, down. Abduction, adduction, side to side. Rotation is around. We should not be causing pain. Not our job. That's physical therapy. Denture care. This is mouth care with an extra step. Sarah says, good morning. I have a question. If I have basic communication skills, is it possible to be a CNA? Sure, absolutely. Communication is important. As a CNA, you've got to be able to communicate with both patients and healthcare providers. So you do need basic communication skills. As far as the physical skills of caregiving go, those can be learned. So yes, basic communication skills are needed to be a CNA. So with denture care, we're going to clean the dentures at the sink, protecting them in case they fall by putting a washcloth in the bottom of the sink. You're going to brush all surfaces of the dentures and put them back into the cup with clean water and on the table for future use. And then you'll clean the mouth they came out of using mouth care techniques we've already learned. Ambulate with a gait belt. This is a fun skill. I like this skill. Make sure there's no obstacles in your way. You're going to put the gait belt around the patient using all of our rules from shoe rules, checking to make sure there's 4 fingers between the belt and the patient. Their feet are flat on the floor. They have shoes on. And you're going to help stand them up on the count of 3 with their hands on your shoulders, your hands on the gait belt. 1, 2, 3. You'll stand. Ask if they're dizzy. Walk them however far we're going to walk. Return back to the chair. Make sure they can feel the chair behind them before we sit them down. Remove the gait belt. Make sure they're seated appropriately. Do your closing. Partial bed bath. This is a washing skill. All of our washing rules apply. We're going to wash what the care plan tells us to. This care plan is very specific. Face, neck, chest, abdomen, back, 1 arm and hand. What if the patient has 2? Yeah, we don't care. Care plan says 1, we're going to do 1. That's right. Not our job. That's right. So just remember your washing rules. You're going to use a paper towel to get the water. You're going to check it. It should feel warm, not hot, not cold. Don't add soap to the basin. Leave it water. Have the patient check the water too. We're going to use the leaves method on the face so that we're not cross-contaminating. So 1 leaf for the first eye, fold it over. Second eye, fold it over. Face, fold it over. Nose last. Set that on your barrier to the side. We're not reusing that. It's got boogers on it. We're going to dry the face. No soap on the face. Then we're going to get a washcloth, wring it out really well, and we're going to soap the top leaf. We just need 1 leaf for the rest of it. We're going to wash the neck, the chest, the abdomen, down 1 arm to the hand, up, and the armpit last. That's got soap on it. Set it aside. You're going to get a washcloth, wring it out really well. You're going to rinse all of those areas. Now, that rinsing washcloth, you can reuse if you want to. Or you can set it aside if you got 5 washcloths. And then you're going to dry, because whatever we wash, we rinse. Whatever we rinse, we dry. Put the new hospital gown on. Turn them on their side by scooting towards you. Turn on their side. And you're going to wash the back, rinse the back, dry the back. And then you're going to get some lotion, warm it up, give them a little back rub. Wipe off the lotion, tie the gown, remove the towel that was protecting the bed, and clean up. Partial bed bath. You've got 19 minutes to get that done. It does not take 19 minutes. Good. Whew. It is almost break time. All right, so let's get into wheelchair. Transfer out of bed and into a wheelchair. This is our overview page, page 72. You can see all the principles involved. We know them all. There is nothing, as far as principles go, that you need to learn to do the skill. You know to follow the care plan. You know to do the opening. You know to evaluate if you need gloves. You know shoe rules, right? Patients have to have shoes if their feet are on the floor. We know how to use a gait belt, and we know how to use the closing. So there's nothing new here that you need to learn. This skill, for somebody with your level of experience, should be able to be completed in 11 minutes or less. You're getting somebody out of bed and into a wheelchair. It does not take 11 minutes. Ever. Maybe 4. 6 if you're slow. 11 is an extreme amount of time. So I want you to slow down. You have all the time you need to do this skill. This skill, if you try to go too fast, you will forget some of the small details. And those small details count big. Anything that has to do with safety is going to count really big on the state exam. Right? Because it doesn't matter how good you are at a skill if you kill your patient doing it. Safety steps count big. Well, transferring out of bed and into a wheelchair is all safety. So every step I'm about to go over with you is going to count really big, really big. Make sense? Good. All right. So if we look at the top page 73, you can see your care plan. It tells us to transfer the resident from bed to a wheelchair. The resident is unable to walk or take steps. Let's time out there for a second. I want you to underline that or highlight it. The resident is unable to walk or take steps. Unable. What does that word mean? Unable. They can't. So if you have that wheelchair positioned too far away from the bed, and that person that is playing your patient has to take a step, you will fail, because our care plan is telling us that they can't take steps. So you've just forced somebody to do something that they cannot do. And if they can't do it, that means it's going to result in a fall. Do you guys see how important that little part of the care plan is? So when we position the wheelchair for this transfer, it's going to be close. And if you think it's close, it's probably not close enough. You should only be able to fit a sheet of paper right here. This, you see how thin that is? You guys see that? That is all I should be able to fit between my patient and the wheelchair. So if I've got a wheelchair right here and I've got a patient right here, I should just barely be able to get a sheet of paper between the edge of the wheelchair and the patient's knee before I stand them up. Because when I stand them up, I'm going to pivot them around, and that wheelchair's got to be right behind their legs so I can sit them down. That is the number one mistake that is made on this skill, is that they have the wheelchair too far away. Thank you. Oh, yeah, just leave it right there. That's good. All right, now let's go back to this. It says a gait or transfer belt is required to transfer the resident, and the resident will stay in the room after the transfer. So we're going to get our patient out of bed. Patients in bed generally don't have shoes on. So what do you think we're going to have to do? Put their shoes on. We're going to put a gait belt on. We're going to get the wheelchair positioned properly. We're going to make sure it's locked so it doesn't roll away from us. And we're going to lift the patient using that same body mechanics we used with ambulate. Lift them up, but instead of walking, we're just going to turn them around, make sure they can feel the wheelchair behind them, and help them sit in the wheelchair. But if I'm going to leave you in a room in a wheelchair, do you want to be facing a wall? No, that can actually feel a little bit punitive, right? It's like somebody's punishing you. I don't know how many of you guys were ever put in a corner when you were a kid, but that's essentially what we're doing here. So when you get somebody into a wheelchair and we're going to leave them in the room for any amount of time, make sure that they're facing something entertaining, whether it's the door, the TV, a window. They need to have something to look at, not a blank wall. Again, psychology. Okay. Make sense? Okay. All right. So in order to understand this, we're going to go over a couple of rules here. If the patient's feet hit the floor, we got to talk about their shoes, which means for this skill, we're actually going to have to put shoes on. for the test, if you get this skill, you have to do it on a live person. So they're going to pair you up with somebody your body size or smaller whenever possible. So let's say that you get this skill. I'm probably going to make you the patient. Now, as I'm checking you guys in, I actually look at your shoes. It's something that the evaluators are going to look at is how you're dressed, how you present yourself. Are you limping? You know, kind of what is your overall level of ability? But I'm also going to look at your shoes because where do I want to be as the evaluator? Where do I want to be? Home, in my pool, drinking my margaritas. That's where I want to be. So if you have to do this skill and you got to put shoes on somebody, I want that to go as quickly as possible. I'm pretty sure you know how to tie shoes. You learned in kindergarten. I don't need to verify that you can tie shoes. So I'm going to look for a patient for you that is your body size or smaller that happens to be wearing slip-on shoes. Now, if I can't find one, you'll have to tie shoes. Okay. But if I can, that's going to be your patient. They're going to try to make this as easy and quick as possible. Are you guys starting to see that they don't ever default to the hardest possibility? They always default to the easiest scenario. You're not trying to prove that you're a master of anything. You're trying to prove that you can be released into the wild and you won't kill patients while you're there. That's what the test is all about. Good? Good. All right. So we're going to put the shoes on the patient before we transfer them. And I got a break on this. So there was a school here locally in our geographic area a couple of years ago. I don't know what they were thinking. But they were training their students to put shoes on while the patient was in bed. So patients laying in bed and they would actually put their shoes on. How many of you guys put your shoes on in bed? Nobody would. That's getting germs all in your sheets. That's getting dirt. I mean, it's just not, don't do that. Right? That's just not, don't do that. I don't know why this school was teaching that. Well, I do. I mean, the rule is if their feet hit the floor, we got to talk about their shoes, but it's okay. You can put the shoes on when the feet are on the floor. You don't have to put the shoes on in the bed. Okay. Don't do that. There's still a video. And the reason I bring that up, there is still a video somewhere out there on YouTube that shows that. So don't do that. Slipper socks are not enough. We're going to put a gait belt on the patient. We're going to check it with 4 fingers. We already know how to do that. And we're going to verbally verify that your patient's feet are flat on the floor before you lift them. So are your feet flat on the floor? I see your feet are on the floor. Are they flat? I don't care how you do it, but you've got to verbally acknowledge this. Because the evaluators can't see what's going on in your brain and they don't know that you know that's important unless you verbalize it. We're going to make them a partner by counting 1, 2, 3 before we lift. And then we're going to swing them around. Remember, they can't take steps. So once we swing them around, using that body mechanics we learned before, 1 foot in front, 1 foot beside. And when we swing them around, this rule still applies. They have to feel that chair behind them before we sit them. So I like to prepare my patients. I like to tell them, I'm going to lift you up and swing you around. When you feel that chair behind you, please say sit, and I'll help you sit. If I prepare them, then I'm not holding their whole body weight while I'm asking them, can you feel the chair? And waiting for them to respond, yes, I can. That's a long time to hold body weight. So I'm going to pick you up, swing you around. When you feel the chair, say sit. Ready? Up, over, sit, down. Especially for those of us that don't have a lot of upper body strength, that can help prevent muscle strain and other injuries. Generally speaking, so I'm going to time out here, has nothing to do, well, it kind of has something to do with this, but time out here. When you go to work, everybody has different strengths and weaknesses. Everybody does. All your coworkers. Some of your coworkers are going to be fantastic at transferring people. They've got a lot of upper body strength. They're kind of built for it. They've got the right center of gravity, and it doesn't really, it's not hard for them to transfer patients. You might be fantastic at Peri-Care. None of your patients ever get urinary tract infections. You're super, super aware of how you're wiping. So you might partner up a little bit, right? And hey, I'll do your Peri-Care if you do my transfers. Good. We can't delegate as CNAs. We're not allowed to say, hey, you go do this. But you can work as a team. You just have to let the nurse know. Hey, Alani, right? Alani and I are going to work together. She's going to do all the Peri-Care. I'm going to do all the transfers. And that way the nurse knows who to come to if something is off. Okay. We all have strengths and we all have weaknesses. Figure out which ones you have and then try to find somebody that can help offset those. The problem with teams used to be a really big thing. Teams used to be awesome because the patient actually got a higher level of quality when we all worked at our strengths, right? The problem is that you've always got that one person that doesn't want to pull their own weight. And if they know they're part of a team and other people will pick up their slack, they'll slack off. And that's kind of what happened to teams, is that, unfortunately, there was just too many people that weren't pulling their own weight as part of the team.
It's like once you see nobody else doing anything and there's no consequences about it.
Right.
Why do I have to do anything?
Right. Why am I killing myself and working so hard if there's no consequence to
Yeah.
poor performance? Yeah, I get it. I get it.
Welcome to ALF.
Yeah. That's poor management, though.
It is, absolutely.
Yeah. I'll tell you a management story. I got to quit telling stories. I'll tell you a management story real quick. When I was brand new, LPN, brand new. First place I worked was a nursing home, and it did not have a good reputation. It just didn't. And I went to work there, and I was absolutely miserable. Nobody got along. All the staff was fighting each other. The patients weren't cared for very well. It deserved its reputation. It just wasn't a good place. Well, management hired a new DON. And none of us had ever known the old DON because she stayed in her office the whole time. Nobody even knew who she was, So we really didn't care. New DON, same situation. This DON, though, was not the same. First day, she didn't introduce herself. She just came around and she started making notes. Nobody liked her. Nobody liked her. Everybody's like, oh my gosh, she's on the warpath. She's, nobody liked her because she was holding people accountable. She would go into a patient's room and hit the call light with a timer. And not only would she time how long it took people to answer the call light, but she would take down the names of everybody that walked by that door. And you got an invitation to come see her at the end of your shift if you were one that walked by that door and didn't address that call light. So it didn't take long to realize that she was not the same kind of DON. If you called off more than twice in a 30-day period, you got let go. She didn't care what the reason was. Your personal life is your personal life. It does not impact my ability to care for these patients. My job is to care for these patients and not to cater to you. If you can't perform the job, you don't need to be here because I need to take care of these people. She was tough. She didn't pull any punches. She was not there to make friends. Within a year, that place went from being the worst place to put your loved ones to having a waiting list. It took a year, but she got rid of all the staff that was a problem. She held people accountable. She made sure that things were done the way they were supposed to be done. And she made sure that the patients were always top priority. And because of that, the reputation changed. So when I hear stories like that, that's a management problem. And you can't be a friend and be a manager. My focus, right? The reason that I'm here is to make sure those people who can't take care of themselves are getting the care they need, not you. Now, I'll support you any way I can. I'll be fair. And if you come to me and tell me that you need time off because of an issue, I will move heaven and earth to make that happen. But in exchange for that, I expect a bit of loyalty from you as well. When I come to you and say, hey, I need somebody to work this shift because somebody else can't, I need you to step up because I'm going to make sure that I can do the same for you when it comes to your turn. I will be in your corner. I will have your back, but you are not my focus. My focus is on the patient. When you have a management team like that, don't leave. Don't leave that place. You're not going to find that very often. That is a good place to work. But it all comes down to the management. If I ran a facility, I would be tough. I would be tough. I would be the one roaming the halls. I would be in at 2 a.m. I would be checking on the night shift. You would never know when I was going to show up. Yep. But my facility would take care of its patients. If you can find that place, man, that is the place. Okay, good. Make sure they can feel the chair behind them. All right, so this is the big step, the big part of the care plan you need to pay attention to. They cannot take steps. This is the number one thing that has failed on this skill. And this one step, it's all it takes, one step. One step will fail this skill. It's not about you. It's not about, oh, I forgot a step. Who's it about? The patient. Yeah. Yeah, it's not about you forgetting. So I read a thing on Facebook this morning in a nurse group that I'm in. Oh, I wanted to throw my phone. Remember, I'm a thrower. So it's a nurse. And they had a JACO inspection, a Joint Commission inspection. We just talked about this on Monday, right? So they had an inspection. And during the inspection, she's a case manager. So she knows better, okay? She's the one that coordinates care, right? These are people that really need to be at the top of their game, right? So she's a case manager. She's only been on the job 3 months, which is still enough time. And she's getting a patient ready for discharge, going over the services that the patient needs, trying to coordinate everything, right? Well, in the care plan, it had that the patient needed orthostatic blood pressures. Now, this means that we're taking a blood pressure with the patient laying down, sitting up, and standing up to see if there's any blood pressure changes, because that tells us something about their accommodation ability. It's important. It's very important. So the care plan had orthostatic blood pressures, and she, case manager, coordinating care, did not do an orthostatic blood pressure. And she's blaming it on the fact that she was being watched by JACO, by Joint Commission. That they distracted me. She was talking to me. I just missed it. What effect? It was all about her. And I wanted to throw my phone, because what part of this is all about you? It's not. You are there to coordinate resources for the patient. Nothing about you. It's about the patient. And because you miss that, now the patient isn't going to get the services they need. That information isn't going to be passed on. The patient is going to get up wherever they are and fall because their blood pressure dropped and there was no accommodation for that. These inspections exist to make sure that the patients get the quality care they deserve. It's not about you. I wanted to throw my phone because this is a nurse and they should know better. Care plans exist for the patient. Everybody has to follow them. Nurses, dietitians, physical therapy, and CNAs. And we all have to follow them. If we're not following the care plan, then what are we doing? That's why if you miss this on the state exam, you will fail this skill. If you fail one skill, you fail the test.
Oh.
So both. Yep. Unhappy. Unhappy.
Don't want to get that haircut.
No, unhappy. I get it. I understand. Oops. All right. So we get the patient turned around, sitting on the side of the bed. We get the shoes on. We're going to put the gait belt on. We're going to get the wheelchair close, but not too close yet. I want it in reach. Don't want it too close yet, because if I get it too close, it's going to interfere with what I got to do. Okay. And I'm going to lock the wheelchair. Well, not yet. Hold on. I'm ahead of myself here. All right, Jake, two things. I'm going to need you to zoom in on me over here. And I'm going to need you to advance slides for me when I tell you. Yeah, but you're going to zoom in a little bit more on the wheelchair itself. Down a little. There you go, right there. All right. So let's talk brakes. Wheelchairs are all about brakes. Brakes are these levers that are right in front of the big wheel. And you should be able to see it up here. I'm going to turn this around so you can see. Yep, this is a brake. And the way it works, there's a little metal tab here. When I pull this lever, that tab bites into the wheel and it keeps it from moving. To disengage the brake, you push the lever and the tab moves away from the wheel and now it can roll freely. Now, go ahead, Jake. You can back up a little. All right. Now, wheelchairs have different brake mechanisms. This one, you pull back to engage the brake. Some of them, you have to push forward to engage the brake. It's the same mechanism, just a different gearing action. So when you go to the testing center and you get this skill, they're going to have to show you how to engage the brakes on your wheelchair. But it's a choice of two. You either push it forward or pull it back, one or the other. I mean, it's not real hard to figure out. And the way you figure it out is all about that tab. Watch that tab. If it bites into the wheel, it's locked. If it is away from the wheel, it's unlocked. Good? Make sense? All right. You can see that here. I've highlighted it for you. The tab has a gap, not locked. The tab pressing into the wheel, locked. Good? All right, Jake, advance, please. No, you're fine. I know it's the mouse thing. I'm sorry.
No, you're fine.
I am not near my.
No, it was trying to change the sources, not the slides.
Oh, okay. All right. So when you walk away from a wheelchair and you've got a patient in it, it has to be locked. Has to be locked. And that's because of this. Floors are rarely level. When you're looking down a hallway, You can actually kind of see the waviness. Concrete is not always completely level. We do a pretty good job, but there's still dips, and wood floors, even worse. Wood floors will really warp. So the problem is that if we have weight in a wheelchair and it's on an unlevel floor, it could start rolling. And because it has weight in it, it's going to pick up momentum as it rolls. And the only thing that's going to stop it is whatever it rolls into, which is probably going to hurt somebody, whether it's the patient in the wheelchair or who they slam into. Now, the reason, so remember, if you've got a patient in a wheelchair, it must be locked. That is a principle. Go ahead, Jake. The reason that this is such a big deal is this: the largest medical negligent lawsuit in Florida occurred in 2004, the largest monetary amount. And it was all about a dementia patient who was strapped into a wheelchair, and that's illegal, by the way. That's a restraint. She was able to access a stairwell like this, and she started to go down the stairs, had no way of stopping herself. She strapped into the wheelchair, and she ultimately died. And it resulted in the biggest negligence lawsuit in Florida. It's a big one. So this is what we call a chain of events. It wasn't one single thing, but the patient should never have been seat belted into a wheelchair. Number one. The wheelchair should never have been unlocked. If the wheelchair was locked, that patient wouldn't have been able to go anywhere. That patient, especially dementia patients, should never have been able to access a stairwell. And that patient should never have been unmonitored. So there were a lot of causes to this tragedy, but at the end of the day, does that make the family feel any better? No, their loved one is still dead. And that amount of money that they won is still not going to make them feel better because their family member is still dead. And they probably have nightmares over how she died. That's horrible. We've got to do better than that. So you do not seatbelt patients into a wheelchair. You do not leave a patient in an unlocked wheelchair. If the patient can self-propel, they can unlock it, go wherever they want to go. It's not a restraint. We're not keeping them confined. They can unlock the wheelchair, go anywhere they want to. But if they can't stop the wheelchair on their own, that's a safety issue. So if they can't stop the wheelchair on their own, they don't need to be unlocked.
What about those wheelchairs with the locks that are on the back?
Okay, so we're going to talk about that. That's a different kind of wheelchair. Okay, so this is a true wheelchair. It has big wheels. So wheelchair is big wheels. You see those little small wheels on the front? Okay, these small wheels are very maneuverable. See how they can turn, right? Big wheels, not as maneuverable. They're bigger, they're fixed. So there is a different kind of chair called a companion chair that has 4 of those small wheels. And that makes it very maneuverable. It can move in pretty much any direction very easily with somebody in it. They're also a little lower to the ground, and they're called companion chairs. And they're designed specifically for people that can pad, right?
Oh.
They sit in the chair and they use their feet to get anywhere they want to go. They can start and stop on their own. So I wouldn't put a dementia patient in here that wasn't able to stop them. That's the key there, stop themselves. So somebody who can't stop themselves would not be eligible for a companion chair.
Okay, but if they can, you don't put the brakes on those because they can't reach.
Right.
away?
We need brakes when we put them in and take them out if they're transfers, so the wheelchair doesn't roll away. So we have to have brakes. But when they're in the wheelchair and self-propelling, no brake. Okay. Good. That would actually be reflected on the care plan. Yep. Good. All right, Jake, thank you. Wheelchair brakes are not a restraint. They're a safety measure, not a restraint. They're safety. And that's why when we leave a wheelchair with a patient in it, they have to be locked. Go ahead. If somebody can control the wheelchair on their own, they can unlock it, go anywhere they want to. It's fine. Go ahead. Seat height differences. This is important. If I put a chair right up next to this wheelchair, you can see it on this screen here. The wheelchair is higher. The seat is higher. Well, in a chair, your chair is created so that your feet can rest flat on the floor, like yours, right? Their feet are flat on the floor. Well, in a wheelchair, we don't want your feet flat on the floor. The whole purpose is I want to take you somewhere. You're mobile. If your feet are flat on the floor, it's going to interfere with mobility. So wheelchairs are a little higher. That causes the legs to dangle, and dangling legs are a danger. Go ahead, Jake. Along the back of your legs, you've got arteries and veins, and those arteries are going to push blood down to your feet. Veins bring blood back to your heart from your feet. This system is already compromised because it has to fight gravity. Now, go ahead, Jake. When we put somebody in a wheelchair, this seat edge, it's fine, you don't have to move, but this seat edge here is going to bite up into the back of the knees, which is going to restrict blood flow. Remember, we're already fighting gravity. We're already a step behind here. So when we put a patient into a wheelchair, that seat bites up into the back of the knees, and that stops blood flow. Everybody with me? If the legs are dangling, if they're not supported, if the feet are just hanging, right? Gravity is pulling down. That means that those blood vessels are absolutely closed off. So now we've got blood pumping into the legs, but no way to get it out of the legs back to the heart because the vessels are closed off. Go ahead, Jake. So we end up with swelling. Okay. So when we have a patient in a wheelchair, their legs should not dangle. We need to have those legs, go ahead, on a footrest to support them, to relieve the pressure on those vessels, to allow blood to move back to the heart. If we don't, this is what happens. This is what an inside of your vein looks like. When you have veins, remember we're working against gravity, right? So we have veins that go from our feet back up to our heart. Well, because of gravity, we've got to have a way, and it's not a high pressure system, we've got to have a way of advancing that blood without letting gravity pull it all down. And what the body does is it creates little compartments. So when the heart beats, blood comes up into this compartment, and then the heart rests. And these valves close to keep the blood in that compartment. And the heart beats again, and it pushes the blood into this compartment. And then the heart rests, and that valve closes. So blood literally climbs like a ladder back to your heart. Good? All right. The problem is if we squish these down and blood can't really get from one compartment to the next, we're going to end up with congestion there. Right? The blood can't move. It can't go anywhere. So that's when the body says, wait, too much. So we exit the fluid. That's where our swelling comes from. Fluid goes from the vessels to the tissues. We get rid of the fluid to make more room. But that means that we have a lot of cells and not a lot of fluid, and the cells are sticky. So they end up clumping together, which puts us at risk for blood clots. So not only do we get swelling that we can see, we've increased our risk for blood clots that we can't. So when you get a patient into a wheelchair, we know their legs are going to dangle. Dangling is not good. So we need to make sure, go ahead, Jake, that we put the feet on the foot pedals to support them. That relieves some of the pressure along that edge of the seat biting into the back of the knees. You guys see why that's important? Leg rests and foot pedals are super important. And the real problem with them, Jake, I need you to zoom again, please. Sorry. Yeah. The real problem is that these leg rests literally just kind of hang in place. So they come off super easy. That took me no effort at all. So chances are that leg rests get lost. You end up with a wheelchair and no leg rests, no foot pedals, because they came off and nobody knows where they are. That's not good enough. We have to go find them. In order to use them, they just literally, there's two little protrusions here. They literally just sit right on those posts. Just like that. They just sit in place. Now, leg rests, when they're in the forward position, they're locked in place. This is a locking mechanism here. There's a latch on the back that I can release, and the leg swings out. Foot pedals fold up and down. Leg rests lock in place. I can't put a patient into this wheelchair or take them out of this wheelchair with this in the way. This is a problem. This is a tripping hazard. I'm not just going to fold those up because I still have a very narrow opening there. Tripping hazard. So in order to get somebody into this wheelchair, I need to fold the foot pedals up and swing the leg rests out of the way. Now I've got a wide open area. I'm going to lock the wheelchair to get my patient in or take them out. But once I get them into the wheelchair, I need to swing these leg rests back in the forward position, fold the foot pedals down, and support their feet. Good? All right, Jake. So this graphic kind of shows you foot pedals, leg rests, wheelchair, and the brakes. Those are the important parts of the wheelchair that you need to know to do this skill. Go ahead. You might have a test question like this on the state exam, and it's showing you a couple of different configurations of the wheelchair. When your patient is in the wheelchair, when it's in use, it should look like mine. Foot pedals down, leg rests forward, in use. When we are transporting the wheelchair, so I'm all done with it, I'm going to go put it in storage. We're going to fold these foot pedals up. And in most cases, for storage, we're going to collapse the wheelchair by pulling up on the center of the seat. And that collapses the wheelchair. But you don't want those leg rests. You need them locked forward. Foot pedals are out of the way, so we can bring the legs together. But you have to have those leg rests locked. The reason is, let's see if I can get my fingers back here. If I've got these just kind of hanging around like this, as I'm transporting it, I have no control over them. They're just swinging freely, which means that they probably are going to injure somebody. So locked in the forward position keeps them nice and secure. And then we've got this one. This is for transfers. Everything out of the way. Foot pedals up, leg rests out, everything out of the way. So you might get these graphics on the state exam and it asks you which one of these is the correct configuration when you're placing a patient into a wheelchair. Yeah, right here. Good? Questions? Do you guys understand why each one of those is important? Go ahead, Jake. All right. This was really sad. I felt so bad for this lady. This is one of those times when you do a good job and you get penalized for it. Okay. This was a secretary or a receptionist at a radiology center. An old lady had come in to get some x-rays done and she was in a wheelchair. Her daughter goes out to get the car and bring it up close so the woman, the patient, can get into the car. No problem. We do this all day, every day. transport was called, no transport came. So the receptionist, she sees the car coming and she knows it's blocking traffic. So she makes the decision as a receptionist. I've been working here a long time. I can figure this out. She makes the decision to take the patient in the wheelchair out to the car. Seems perfectly reasonable, doesn't it? And she goes to help the patient out of the wheelchair and into the car, but she had not been trained on how to use a wheelchair properly. And the leg rests and the foot pedals were not addressed. They were still in the forward position. And the patient had to try to step over them and got tangled up and ended up falling. Well, the way that she fell was between the car and the wheelchair, and she ended up breaking her leg. That receptionist was fired. Why do you think? No, all she was trying to do was a good job. She was trying to be helpful. Why do you think she was fired? That's right. She was not trained to do it. It was outside of her scope of practice. And even though she thought she was doing a good deed, she ended up causing injury. If you have not been trained to do something, don't think to yourself, I can figure it out. Or I've watched it done and I think I know how. There's always something about that skill that you don't know. And this class should have taught you that. I want you to think back to how much you have learned in this class. Every bit of that was something you did not know before taking the class. Every skill that you learn from here forward, there is going to be something about that skill you did not know. And that's why training is important. Make sense? I feel bad for the lady, the receptionist. I really do. She was trying to do something nice. But does that erase the broken leg?
Tell her at least don't do things out of your scope of practice. Seems like
I don't know. Well, I don't know that anybody specifically said that, because we should already know not to do things outside of our scope of practice.
Like, you're hired as a receptionist. You're not thinking medical procedures. You're just being a helpful person.
Right. Exactly. So no, I don't think that anybody is ever going to tell you not to do things outside of your scope of practice.
I would assume you would be if you're working in any medical position.
Well, it's kind of like,
Lawsuits, really.
yeah. Jake, go ahead and recenter on me, please. So it's kind of like if you go to work at, let's pick on Chili's. You got to work at Chili's, right? And you're hired as a server. And they're probably not going to tell you not touch the fryer. Why would they? Because you're hired as a server.
I would assume just because legal America living here, legal liability, right? Position is position based, and you have insurance for certain.
Well, the problem is that if they have to tell you everything that you can't do, they're going to be there a while. They're going to focus on what they want you to do. Everything outside of that, not your job. So they're not going to tell you, don't touch the mop. We have housekeeping for that. Don't touch the fryer. Don't seat people, because that's the hostess's job. Don't go around like the manager and make sure everybody's meal is good. Don't go to tables that aren't yours. They're not going to tell you all that. They're just going to focus on what your job is. Outside of that is outside of your scope of practice. So no, I don't think that she was specifically told, don't do anything outside of your scope of practice, and you won't be either. That's just something that we're all supposed to know. Good? Good. Okay, Jake. All right, so we're going to fold those foot pedals up, get those leg rests out of the way, get the, go ahead, one more. We're going to have the patient sitting on the side of the bed, and we learned this last class, arm under the shoulders and over the knees, not under the knees, over the knees, and we're going to pivot them around to the side of the bed in a sitting position. We already have the wheelchair prepared, foot pedals up, leg rests out. So now that we've got the patient sitting on the side of the bed, we're going to put their shoes on, Go ahead. Go ahead. One more. We're going to put the gait belt on and we're going to get that wheelchair close. Do you see that graphic? That is still not close enough. I can fit more than a sheet of paper. I can fit more than a sheet of paper there. This seat edge needs to be almost touching that patient. Because when I pick that patient up and swing them around, look at where his feet are. His knees are not going to be against that seat. You guys see that? When you swing that patient around, their knees should be against that seat. Go ahead. And then we'll lock the wheels before we transfer them. All right, I got it from here, Jake. Thank you. Make sure the gait belt is on appropriately and we assume the right body mechanics position. We're going to lift with our legs, not our back, on the count of 3. Swing them around, and when they can feel that wheelchair behind their legs, we're going to help them sit in it. Make sure that their feet are on the foot pedals after the transfer. Leg rests are back in the front position now, and then we can lock the wheelchair, we can remove the gait belt and make sure that they're sitting appropriately. That is the entire skill. It doesn't take 11 minutes. Let me show you this video. We've got to get going. I'll show you this video and then we'll take our break. Good afternoon, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
I'm well. How are you?
Fantastic. Would you like to get out of bed and into the wheelchair?
Yes, that'd be great.
Okay, I'll be happy to help you with that. Let me close your curtain, wash my hands, get my supplies, and I'll be right back. Okay, I'll grab the gait belt. And I'm going to bring the wheelchair within reach, but not too close to the bed. All right, Mr. Jones, I'm just going to remove your sheet. We'll pull it all the way to the end of the bed. And I'm going to help you sit up on the edge of the bed. So to do that, can you scoot your body toward me? Bed is locked. You're going to cross your arms over your chest and relax. I'll do all the work. I'm just going to pivot you around so you're sitting on the side of the bed. Please let me know if you get dizzy or unstable at all. So I'm going to wide base of support, leaning against the bed, making sure the wheels are locked. I'm going to place one arm all the way under the shoulders and the other arm over the knees, bending at the knees, not the waist, and we're going to pivot. 1, 2, 3. Good?
Yes.
Okay, you can relax your arms. I'm going to help you put your shoes on now. Okay, first shoe and the second shoe. And are your feet flat on the floor?
Yes.
I'm going to place this gait belt around your waist, making sure that it's not twisted or kinked. And we'll secure it by sliding the gait belt into the first guard, pulling it so that it's snug. We'll check it with 4 fingers, and then slide it through the second guard.
I'm going to bring the wheelchair close at a slight angle, almost touching the patient. And we'll lock the wheels. All right, Mr. Jones, can you bring your feet together and back a little? Are your feet flat on the floor?
Yes.
You're going to place your hands on my shoulders. I'm going to lift you to a standing position, pivot you, and when you feel that seat behind your knees, I want you to say sit, and I'll help you sit.
Okay.
Okay, you're going to place your hands up here. And on the count of 3, we're going to lift and pivot. 1, 2, 3.
Sit.
And we'll remove that gait belt. Okay, and I'm just going to bring the gait belt behind you and turn you around to get your feet onto the foot pedals. So we're going to turn around. I'm going to bring the first foot pedal forward. Make sure it locks into place. And then place the foot on the foot pedal. We'll then lock the wheelchair. I'll lock this side, support your leg, bring the leg rest and the foot pedal, and support the foot. Are you comfortable?
Yes.
Is there anything else I can get for you while I'm here?
No, thank you.
Would you like a magazine before I go?
No, thank you.
Let me get your call light. Here's your call light. If you need anything at all, just press that red button and somebody will be happy to come help. I'm going to open the curtain and go wash my hands. On the way, I'll return the gait belt to storage. After washing my hands, I'll think about my skill, make any corrections, and tell the evaluator my skill is done.
Go ahead and take our break. Come back in 15 minutes. All right. Next skill we're going to get into is feeding a resident. And we already covered some of this during last class. So I'll be kind of speeding through a review really quickly of intake and output and conversions. So this is our overview. There's nothing here to learn. We know to follow the care plan, do the opening. We know to decide if gloves are going to be worn. Barrier is unique on this one because we don't need an actual barrier on the table. Your food tray becomes your barrier. So you don't need a, chucks or underpad for a barrier. Linen rules are going to apply because we have to have a towel or a clothing protector of some sort for the patient. Don't hold it against your uniform. And we know to do our closing. This is a live patient skill. That means one of you may be fed. For the test, it's a single serve pudding or applesauce cup, and you are going to receive specific information on what to do for this particular skill. You're only going to be taking 4 bites. That's it. And then refusing. All right, so if you look at the top page 109, we get our care plan, and it says feed the resident a snack who is sitting or who is unable to feed him or herself. The resident is sitting in a chair in an inappropriate position for eating. I don't care what your eyes say. Your patient, according to the care plan, is not sitting up straight. So for this skill, you actually have to tell the patient, please sit up straight. Remember I said if you're a patient, you're going to get specific instructions. This is one of the instructions you're going to be given. Slump or slouch. Well, to you, this might be good enough. But to anybody looking at you, this may not look like if you've ever seen a 10-year-old kid, they all eat like this, right? So that's why the care plan says inappropriate position for eating. You have to address this. Okay. And then it says document the intake on the food and fluid intake form. You can see a example of the form there in the second column, or if you want the full size version, it's going to be located on page 164, I believe, or 160. 160. Go to 164. Let me look. Yeah, that page. 169, sorry. That's the full size. So this skill is a little different than all the other skills that we do. It doesn't follow all of our normal rules. So first of all, we don't use a barrier because food tray is our barrier. We don't close the privacy curtain. And that's because eating is a social event. People gather in groups to eat. You have to have some sort of socialization during eating. Generally speaking, if you don't have another human to talk to, you'll turn on the TV or listen to an audiobook or read a cereal box. But there is some sort of socialization happening during eating. If you isolate the patient, they do not eat well. Along the same lines, you actually have to have a conversation with the patient for this skill, and it's graded. Now, what you say isn't graded, but the fact that you have a conversation is. You must talk to your patient. And this is the one skill where you don't want to tell them step by step what you're doing, because how awkward is that? I'm going to put some pudding on the spoon, and now I'm going to bring the spoon up to your mouth, and you're going to open. That's very condescending and not what we're going to be doing. So for this skill, you're going to have a conversation that is not based on what you are doing, your steps. You can make something up. They're showing a movie on the big screen later today. Bingo jackpot's up to $2. Are you interested? Did you know those little kids are coming for the Halloween trick-or-treating event here? Oh, I love those little kids when they're all dressed. I don't care what you say. Just something to socialize them. Okay? Good. This is the only skill that requires you pull up a chair and sit. You cannot stand over somebody to feed them. That power dynamic will cause them to feel rushed. It also causes them to feel inferior, and they've already got that issue because of having to be fed. There's a psychological complication with this skill. This is the hardest skill to be a patient for. And I know some of you are like, we got Peri-Care coming up. but this is the hardest skill to be a patient for because of psychological reasons. Eating is the very first skill you become independent at. You learn how to hold a bottle long before you sit, stand, crawl, or walk. You are picking up fruit and Cheerios off of a high chair tray and getting them to your mouth before you can even fully sit on your own and before you recognize what hunger actually is. Eating is the first skill you become independent at. So when you lose the ability to feed yourself, it affects you psychologically in a very big way. Patients that have to be fed generally do not eat well. They will take a few bites and say they're done. They are at risk for malnourishment. And even more so if the person feeding them is acting like it's a big imposition or an inconvenience. If my attention is on the TV and I'm just shoveling food into your mouth, that patient is going to feel it. So the way that you approach this, it is going to play a huge role in how your patient reacts to you. Make sense? Okay. It's different when we're playing around with this. Like you can feed somebody at home and it's all a big joke and you know, it hits a little different. But when you legitimately cannot feed yourself, this is the lowest point of a patient's life. Most people that have to be fed will end up with some sort of a depression over it. Feelings of worthlessness and helplessness are huge here. So we want to do everything we can to avoid that. Okay. So we're going to ensure that they're sitting upright. We're going to offer a hand wipe. Most people wash their hands before they eat. It's part of the eating ritual. And we're going to give them a hand wipe to help with that. But it's also important because even though they can't feed themselves, if things start falling out of their mouth, they might bring their hands up to push it back in, and we don't want dirty hands while we're feeding the patient. So giving them a hand wipe is important here. We're going to offer a clothing protector. They may not want it, and that's okay. They might want, I need one. You offer me a clothing protector, I'm going to say, please, because I wear everything. Right? So everybody's a little bit different on, we're going to offer the clothing protector. We're going to sit facing them as we feed them. We're going to offer a drink before feeding and every 2 to 3 bites. You do not eat the way everybody else eats. You think you do, but you don't. Some of you will drink an entire glass of water before you eat. My aunt was like that. Every meal, she would drink a whole glass of water. She used to be a model. And they were taught to drink water before you ate, and it helped fill you up. Didn't work for me. I've tried it. It doesn't work. Some people will drink while they're eating. That's me. I have to have a bite, and then I take a sip. Some people don't drink at all while they're eating. They wait until after they eat, and that's fine too. You do not eat the way other people eat. And the problem is you're going to try to feed the patient the way you eat. But that may not be the way they eat. Does that make sense? How many of you guys don't like your foods to touch? Yep. How many of you eat all of one thing on your plate before you go to the next thing? How many of you take a little bite here, a little bite there? Some of you like your corn and mashed potatoes mixed. Others are like, I'm about to throw up now, thank you. Do not assume the way you eat is the way your patients eat. Pureed does not mean no taste. It means no chew. Do not mix pureed foods together. Just because they're pureed doesn't mean they're no taste. Good? All right, you're going to feed slowly. The spoon should be half full or less. That's it. Half full or less. So you're not overloading the spoon to get it done quick. We're going to feed slowly. Give them time to chew and swallow. Wait until they look ready for the next bite, or ask them, are you ready for another bite? You're going to have a conversation while you're feeding them. And you're going to give them time to respond after they swallow before you move on. Conversation. You guys all have conversations with eating. You just don't realize it. And I'll prove it to you. Go into a restaurant after class today. Will it be completely silent? Those people are there to eat. That's the only reason they're there. There is no other reason for a person to be at a restaurant other than eating. That is what they're there to do. And yet, it's one of the noisiest environments. So don't tell me people don't talk while they eat. You're used to having a conversation while you eat. No, you don't talk with your mouth full. You chew and swallow and then say what you're going to say while somebody else is chewing. Good? Okay. You're going to encourage them once they stop eating. For the test, they're going to be told to take 4 bites and then refuse. That's it. That's all they're going to eat is 4 bites. You're going to offer a drink before and every 2 or 3 bites. So by the time we get to 4, you should have offered a drink in there. At 4, they're going to take the bite and then they're going to say, I'm done, I'm finished, no more, whatever they're going to say. You are going to encourage them. You're not going to say, oh, thank God, I got a million things to do and you're holding me up. You are going to encourage them. And the way that we're going to do that, there's 3 ways you can encourage somebody. I want you to use at least 2. The first thing that I say is, are you sure you don't want just 1 more bite from me? And that makes them feel that I'm not rushing them, that this is important, right? So turn up the charm. The second thing I'm going to do is offer to get them something else. We've all had those days. You make something or you buy something, you take a bite and you're like, nope, not it. Not what I was looking for. Well, your patient doesn't have a kitchen they can go to raid the fridge. If they're only taking a few bites, we probably need to recognize that this may not be it for them. And we can offer something else. Would you like something else from the kitchen? I've got sandwiches. Does that sound better? I know she didn't eat much. Are you okay? The third thing I'm going to do is tell them there is food available later if they get hungry. That lets them know this isn't an all or nothing type of thing. I'm concerned about their nutrition. After we do that, we're going to leave their mouth clean. So use that towel or clothing protector if they're wearing it to wipe off, or use the napkin on the tray, but leave their mouth clean. And then we're going to perform our closing. Now, part of our closing is documentation. So we're going to make sure that all of our closing is done. Thank you very much, Ms. Jones. Is there anything else I can get for you while I'm here? Your bed's in the low, I know they're sitting in a chair, but I'm still going to talk about the bed. Bed's in the low position. You've got your call light. Your environment is clean. I'm going to go ahead and open the curtain and go wash my hands. After washing my hands, I'm going to document and then go wash my hands again. Good? Now, documentation for this skill is going to be done on a specific form. This is the form that we're going to use. It's going to ask us if we are giving them a snack or a meal. What did our care plan say? Snack. So we're going to check that box. Your patient is only taking 4 bites and they're half full, half spoonfuls. So how much are they eating? Well, for the test, 4 half full spoonfuls of pudding or applesauce. That's it. Yeah, 25%. For the test, it's going to be 25%. If you fed them half of that container, you overfilled your spoon. You guys get that? Now, liquids, that's going to depend on the patient, because your patient for the test might have a dry mouth because they're getting ready to test and they're a little nervous. They might drink that whole cup. Liquid, you'll have to measure. But I can tell you the food should be 25%. If you gave them more than that, you went off track somewhere. All right, so details are mattering here. We're going to offer a hand wipe. We'll offer a clothing protector. We're going to offer a drink before feeding and every 2 or 3 bites. We're going to let them lead. We're going to feed slow, and the spoon should only be half full, and they're only getting 4 bites before they refuse. And then we are going to encourage them to keep eating. Don't use childlike feeding techniques. No planes, trains, or automobiles here. Nope. Adults. We are not doing that for the test. In a clinical setting, there will be patients you can play around with. I am absolutely sure. Pick and choose wisely. You try to do that to my grandmother and she will bite you. She is not a child, and she'll tell you in no uncertain terms, I am not a child. So pick and choose. But yes, there are patients I have absolutely done choo-choo train with because I'm trying to get them to engage, but not for the test. Now, we did go over this at the end of last class. Remember, this is a quarter feeding scale, which means that we're going to pick one of these 5, 0, 25, 50, 75, or 100 when we're estimating food intake. Let me go. All right. So we talked about this last class too. This is the lesson on intake and output, and I told you to go ahead and read this on your own as well. So let me show you this video, feeding a resident. You will be feeding a live person for the exam. You're only feeding them 4 half full spoons. So this takes maybe 3 to 4 minutes, maybe. They give us, I think, 9 to do it, but it's pretty quick. Go ahead, Jake.
Good afternoon, Mr. Jones. My name is Patty. I'm your CNA today. Could I ask you to sit up straight before we get started, please? How are you?
I'm good.
Fantastic. Would you like to eat a snack?
Yes, that'd be lovely.
Okay, I'd be happy to help you with that. Let me go wash my hands, get my supplies, and I'll be right back. Okay, Mr. Jones, I'll give you a hand wipe so you can clean your hands before we feed you. Okay, would you like to take the hand wipe?
Yes, please. Thank you.
And go ahead and clean your hands. Thank you very much. I'll dispose of this in the trash. And would you like a clothing protector?
Yes, please.
I'm going to go get one for you. Okay, Mr. Jones, I'm going to take this clothing protector and put it over your chest. This will just protect your clothing while I feed you. And I'm going to pull up a chair. How are you doing today?
Very good.
Wonderful. Would you like a sip of water?
Yes, please.
Okay. And we have cinnamon applesauce. How does that sound?
Great.
Wonderful. Here we go. We're going to fill the spoon less than half full. And do you enjoy sports?
Yes.
What sport do you like?
Football.
Oh, I do too. Did you watch the big game yesterday?
I was so happy my team won.
Oh, it was such a great game. I couldn't believe in that last quarter what happened. Another bite?
Yes, please.
There you go. Would you like a drink?
Yes, please.
Okay. Good?
Yes.
All right. Yeah, my favorite team doesn't win very often. Usually when I'm watching, they're guaranteed to lose.
Usually for me as well.
Would you like another bite?
No, thank you.
Are you sure?
Yes.
Okay. Can I get you something else from the kitchen?
No, thank you.
Okay, if you get hungry later, please let me know.
I will.
Okay. All right, I'm just going to take this clothing protector off. And we'll clean your face. I'm going to put this in dirty linen. I'm going to dispose of all the disposables. And we'll return the tray to the bedside table. Just going to move this to the side. And are you comfortable?
Yes.
Is there anything else I can get for you while I'm here?
No, thank you.
Would you like a magazine before I go?
No, thank you.
Let me get your call light for you. There's your
Thank you.
call light. If you need anything at all, just hit that red button. We'll be happy to come help. I'm going to go wash my hands and document. After washing my hands, I'll document the amount of food the patient ate and the amount of fluid that they drank. Once I'm done documenting, I'm going to go wash my hands one final time. After washing my hands, I'll think about the steps of my skill, make any corrections, and tell the evaluator my skill is done.
Okay, any questions? All right, we're going to move on to Peri-Care. This is the last skill on the syllabus for today. We're going to get Peri-Care done, and then we're going to transition into blood pressure. All right, so if you look at page 152, this is our overview of Peri-Care. You can see all of the principles that are involved, which are almost all of them. We're going to follow the care plan. We're going to do our opening. We're going to use gloves because we are in a private area and there's body fluids involved. We are going to use a barrier on the table. We'll need a privacy blanket. Linen rules apply. The patient always needs to be in the middle of the bed during this skill, and we are going to be turning them to clean their backside. Washing rules apply. Basin cleaning applies, and our closing. So a lot of principles are involved in this skill, but you know all of them. If you look at the top of page 153, you see our care plan for this skill. It tells us the female patient has been incontinent of urine and needs perineal care. The pad under the resident is wet, but the gown and the bedding is dry. That is a miracle. It will never happen in real life. This is a mannequin skill, so we're going to take the gift they give us. Because it's a mannequin skill, the pad will actually not be wet. Even though the care plan tells us it is, we're going to use our imagination. The pad's not really going to be wet here. Okay, good. Look at the amount of supplies you need for this skill. It's extensive. You have to learn your supplies. Flashcards are your friend. Let's talk a little bit about what incontinence is, though. Because if our patient is incontinent, we have to know what that actually means. So we're going to review a normally working urinary system first. This is 5th grade anatomy. We have 2 kidneys. Those kidneys filter blood and produce urine 24 hours a day, 7 days a week, never takes a break. No time off for good behavior, no vacations. 24 hours a day. Filters blood. It makes urine. That urine drips down tubes called ureters, and it gets produced drip by drip. So your kidneys don't just like hang out and then all of a sudden go to work and then hang out again. It's constant. So drip, 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 drip. All of those drips end up in a Ziploc bag that we call the bladder. All your bladder does is holds on to that urine. There's a valve at the bottom of the bladder that, when closed, like a Ziploc bag, will keep everything in here. When you open that valve, whatever's in here is going to come out. And that's what happens when we go to the bathroom. When we go to the bathroom, we open that valve, allowing the urine from the bladder to the outside world. When we're done, the valve closes at the base of the bladder, and now it's closed and ready to fill up again over the next several hours. So when your patient is incontinent, that whole system still works. Everything is exactly the same. Your kidneys still filter blood and produce urine 24 hours a day, drip, drip, drip. Those drips still go down ureters to the bladder, drip, 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 24 hours a day. What is broken here is the valve. That's what's broken. The valve is not closed. So all those drips are going to come out. That means that your incontinent patient is going to be wet 24 hours a day. Drip, 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 drip. If you have a patient that is dry, 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 really, really wet, you do not have an incontinent patient. That valve is working. What you have are incompetent staff members that aren't getting to that patient to the bathroom. You have lazy staff. So when you have a care plan that tells you to check and change your patients every 2 hours around the clock, that means that patient should be incontinent. If they aren't wet, that's a problem. If you have a check and change every 2 hours around the clock and they aren't wet, that's a problem. That needs to be reported. Because that patient should be wet all the time. Make sense? Okay. All right. The problem here is that adult urine is not like baby urine. Our urine acidity is based on what we eat and drink. And as adults, we like acid. Acid makes things taste good. So the body removes the acid in the form of urine. So adult urine, way more acidic. Babies eat formula, rice, Cheerios, very mild stuff, hardly any acid. Their urine is very mild. So you can put a diaper on a baby, put them to bed, let them sleep all the way through the night. When you wake them up the next morning, they still have skin on their little tushes. You try to do that with an adult, that acid will eat their skin. So when you have a patient that is incontinent, wet, 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 drip, 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 you can't leave that urine against the skin for a very long period of time because it will eat the skin. Good? So that means that we are going to change them and clean them every 2 hours around the clock. We're not going to let them sleep all night. Good? Makes sense? Now, a lot of times we use something called adult briefs. We don't call them diapers. Diapers are for babies. These are adults, adult briefs. You can also refer to them as depends as well. But there's a problem with these. When they're out of bed, perfectly acceptable. Nobody wants to wet themselves in public. I mean, that's a dignity issue. That's fine. We still have to clean and change them every 2 hours around the clock. But there's a problem with them. They're holding in body heat. They're holding the urine right up next to the skin. And they're blocking out light. So we end up with warm, dark, moist. What kind of things grow there? Pathogens, all the bad guys. So when we have an adult brief on a patient, good cleaning and frequent changing is essential. Because your patient will probably end up with some sort of an infection, a yeast infection, a fungal infection, a urinary tract infection, a skin infection, but they will end up with something just because of the environment.
Are underpads the same as barriers?
Yes. Yeah. Yeah.
If you're caring for a patient and they do have one of these issues, like urinary tract infection or yeast infection, would that be on the CNA? Would that be like CNA worried problem?
Probably. I mean, there's a lot of factors that would go into it. Nobody's going to like garnish your pay or anything.
Right, no, but you'd still be like,
But
this guy got it.
as a nurse, I'm going to look at my patient and they have an infection. The first thing I'm going to do is turn to my CNA and say, have you been changing this patient and cleaning them well every 2 hours around the clock? Now, if you say yes, and you're telling me that you've been diligent and you've done your job, and now that tells me as a nurse, I need to look a little further to figure out if there's something metabolically going on with this patient I need to be concerned about. So yes, you are held accountable for it, but it's more along the lines of how did we get here? And is there something more to the story that I've got to discover? Okay. Make sense? All right. So adult briefs can be used, and they are used quite frequently. We're still going to clean and change every 2 hours. But if the patient is in bed, there's a better way. If you have the patient in bed, not in an adult brief, if we just have a pad underneath them to collect the urine, that allows light and air to circulate and it pulls the urine away from the skin. So we end up with fewer infections. This is called open to air. So we end up with fewer infections this way. Now, not all your patients are going to be comfortable being open to air. Remember, they're laying down, they're vulnerable, right? They're in a strange place surrounded by strangers. They may want an extra layer of protection, and that's okay. But if we have skin issues a lot of time, or we have a propensity for infections, a lot of times we'll have our patients open to air. And that's how this skill is set up. Your mannequin is laying on a pad open to air. That pad is wet. It's not really, but we're going to pretend it's wet. But let's think about that pad for just a second. That pad has urine on it. That urine, when it comes out of the body, is about 100 to 101 degrees. Remember, body temperature is 98.6. Urine is made in your furnace area. It's going to be just a little bit warmer, so 100 to 101 degrees when it comes out. Now, that 100-degree urine is going to spread out on that pad and encounter 75-degree air. Room temperature always wins. You guys remember that? So what's going to happen to that urine? It comes out 100 degrees. It hits the pad, spreads out. What happens to the temperature? It's going to cool down to about room temperature. 75 doesn't sound too bad when we're talking about air, but 75-degree water, that's cold. So what do you think that pad is going to feel like to your patient? Cold, wet, and probably a little slimy. Yeah. So what do you think the first thing your patient's going to want to do is? Yeah, change that pad. Change that pad. Get me on something dry, please. Okay. And that's all because as the urine exits the body, it's going to encounter air temperature and that's going to cool it down. So we're going to change that pad first. Let's get the patient comfortable. But now we got a wet butt on a clean pad. So when we're done cleaning the patient, we clean the front, we turn them over, clean the back. We're done cleaning the patient. We need a clean pad for the clean butt. So this skill requires 2 chucks. One before you start cleaning, and then a dry one at the end to leave them on for the next 2 hours. Remember, we're cleaning and changing every 2 hours around the clock. Make sense?
Problem with the previous slide. I just said there, let's change the pad first.
Right.
But I thought I just heard you say you're going to do the clean the patient first, and then you're going to take care of the pad.
So the pad is wet, has urine on it, feels cold to the patient. So we're going to change that pad out.
Well, that's going to be immediate. They're going to still be dirty.
We have a dirty butt now on a clean pad. Okay, because we changed the pad. So dirty butt on the clean pad. We're going to clean the front of the patient. We're going to turn them over, clean the backside because their backside has urine on it, right? So we clean the front of the patient, turn them over, clean the backside, and then we change that pad again so that we have a clean butt on a clean pad for the next 2 hours. So this skill requires 2 chucks. Got it? Do you understand why? Okay. All right. So our washing rules are going to apply here. We're not going to put soap in the basin. We're going to use a paper towel to turn the faucet on. We're going to check it with our wrists. It should feel warm and cold. The patient's going to check it too. But in this case, your patient's the mannequin. So who do you think's actually checking the temperature? The evaluator. Make sure it's warm. Russ. Oh, Russ. Hey, Russ.
Just dropping a thanks to you and Jacob. Took my exams yesterday and 100% at both sections. Congratulations. Oh, I'm so proud of you. So proud. He is from our last class. So congratulations to Russ. So we're going to use all of our washing rules. This is a wet body opening, so we're going to need the leaves method. The same thing that we just learned on Monday, we're going to use again for this particular skill. Whatever we wash, we rinse. Whatever we rinse, we dry. Don't get our surface wet. And no lotion is required for this one. So basins or no soap zones, use paper towel. I just went over all this. I forget to advance. All right, so we're going to follow the care plan. The female patient has been incontinent of urine and needs perineal care. The pad under the resident is wet. A hospital gown and bedding is dry. So we're going to start with our opening. We'll get our barrier and put it on the table. We're going to get our water. We're going to check it. They're going to check it. We're going to use a privacy blanket to keep them covered during the skill. And yes, you do need gloves. First thing your gloves should touch is the patient. So now we're to the point that we're ready to start the skill. We're going to change out this chucks. And you already know how to do this. You just don't know you know how to do this. Clean rolls toward me. Dirty rolls away. So the same way that you changed that sheet for occupied bed is how we're going to change the chucks for Peri-Care. You already know how to do this. Okay. Good. All right. We are going to use privacy blanket for this skill. And we're going to put it on and pull the sheet down underneath like we do. But at some point, I have to expose her to clean her. There's no way around this, right? I got to be able to see what I'm doing. Plus, I got to make observations. But I want to minimize the exposure. I want to only focus on the area I need to be at. So when I do this, I'm going to roll that gown up inside the blanket. So I'm going to roll like this so that the gown is rolled inside the blanket. And then once I have the peri area exposed, I'm going to place a towel over the legs. So the only area that should be exposed is the one that I'm currently washing. Good? Makes sense? This sheet really should be up a little bit further.
For the back, do you do the Sims position?
No, we're going to get there. Hold on one second. Yeah, we're going to get there. So go ahead.
So like when you roll the gown up in the blanket, I'm holding on to it.
Oops. So let me show you why we're doing that. Okay. And we're going to pretend I have gloves on in a minute. So first, I'm going to put the privacy blanket on. No gloves yet. I'm going to lay it over. And I'm going to pull the sheet down to about her knees. I really don't need to go down any further than that. Okay. So now I need to expose her. First, I would change the pad under her. That's going to be the first thing I do. And now, so I've got gloves on because I can't touch that pad without gloves. So now I've got gloves on. I've changed the pad out from under her. And now I'm going to take this blanket and I'm going to roll the gown up inside the blanket, just like this, to expose the peri area and put a towel on her legs just to minimize exposure, just like this. Okay. Now, why did I roll the gown up? Because at the end, when I'm done cleaning, okay, we haven't got to cleaning yet. I got to show you cleaning in just a minute. I'm done cleaning. I've got to bring all of this stuff back down. My gloves are not clean. I don't want to touch her gown with unclean gloves. So by rolling the gown inside the blanket, I can unroll it and cover her up without ever touching her gown. Make sense? That is way different than that. You guys get that?
This should make everybody uncomfortable. Are you uncomfortable yet? I'll stand here until you are. This should be uncomfortable. This is clinical. Do you see the difference? Both are exposed. This is different. Make sense? Good? I'll probably get flagged. All right. And again, not to belabor this point, but when you're putting a towel over her legs, right, to minimize exposure, you're also covering her knees, right? No knobby knees. And that's one of the reasons I say it that way, because I want you to start thinking about the exposure that that patient is feeling. Good? Good. All right, so we're going to wring our washcloths out thoroughly before we put soap on them. And because we're washing a wet body opening, we're going to need 5 leaves for this. So we have our washcloth, we wring it out thoroughly, and we soaped 5 leaves. So I put soap and I folded. I put soap and I folded. I put soap. I folded. I put soap. I folded and I put soap. I have 5 leaves soaped. So now I'm going to hold it in my hand like we did last class. And I'm going to start at the top of her peri area. I'm probably going to use the heel of my hand at the top of the peri area and pull up and open just a little bit so I can get down the center. So I'm going to pull up and open. I can't get my hand up that high. Up and open, and I'm going to go right down the center, one direction only. Once I get to the bottom, I'm going to pull away. We don't go down and back up. One direction only. So top, down the center, move away, fold it over. Top to bottom on the outside, fold it over. Top to bottom down the other outside of the labia, fold it over. This area between the leg and the groin, this skin fold, this crease, top to bottom, move away, fold it over, top to bottom, move away, set it on my barrier. Now, whatever we wash, we rinse the exact same way, always going top to bottom. So I'm going to get my second washcloth out, wring it out really, really well. No drippy wet washcloths. And I'm going to do the same thing. Middle, side, side, skin fold, skin fold. We're going to put that on our barrier. And then we're going to cover the patient. I'm sorry, we're going to dry, because whatever we rinse, we dry, top to bottom. And then we're going to cover that patient back up. Minimize exposure. We only need her open for the time that we're cleaning. Cover her back up. Now I need to clean her backside. So I'm going to scoot her toward me. Remember, scoot and roll. Roll her up on her side, facing away from me, and that evaluator will hold the mannequin. Once I get her on her side, then I'm going to wash. So I'm going to take washcloth number 3, wring it out really well, no drippy wet washcloths, and I'm going to soap 4 leaves this time. 5 for the front, 4 for the back. So soap, fold, soap, fold, soap, fold, soap, fold. Ready to clean. I'm going to start at the anal opening and go up that center crease. Never back down. Anal opening, up. Don't do this. Don't go back down. Anal opening, up, center crease. I'm going to fold that over. Now I'm going to clean one buttocks, fold that over, clean the other cheek, fold that over, and then the last leaf is going to go up that center crease one more time because it's a riverbed. All the urine's going to run right up that center crease. So whatever we wash, I'm going to set that aside on my barrier. We, rinse the exact same way. So I get washcloth number 4, wring it out really well. I'm going to go up the center crease, fold, one cheek, fold, the other cheek, fold, up the center crease again. And now that they're on their backside, okay, I've washed, I've rinsed, I'm going to dry with a towel, just same direction. But they're in a good position now to change the chucks underneath them. Clean rolls toward me. Dry. Dirty rolls away. So we're going to change the chucks. And now we have a clean butt on a clean chucks in the middle of the bed. But they're still covered by a privacy blanket, and I got all this stuff to take care of. And I need my gloves on to take care of all this stuff. I know where it's been. And I can't touch that sheet that's going to go right up next to her face with these gloves. So I have to take care of my things first, put all of my dirty linen away, clean my basin, get it back in the drawer with paper towels. Then I can take my gloves off. So I'm going to put my dirty linens away, clean and store my supplies, take my gloves off, and then I can take that blanket off and pull the sheet up and do my closing. You guys see that you know all these steps already? There was nothing new other than what is incontinence. You know the steps here. We've covered them before. We've just had to put them in a little bit different order. Good? You look perplexed.
So for the partial bed bath, when we went over that, you said that we could use the washcloth to rinse the soap afterwards. We don't apply that here.
No, because anything that has touched a wet body opening cannot be reused. If it has just rinsed skin, intact skin, it can be reused. Right, because we're just touching intact skin. But that's why we didn't use the face washcloth anywhere else, because of wet body openings.
When you dry, are you just going one wipe or?
Dry it till it's dry. That's because it's clean. It's clean. So it's fine. It's clean. Yeah.
Maybe I rewatched this thingamabobbers, but what I understood after you clean them and do that step, you're not supposed. You're dirty. But you gotta help them roll back into this, be in the comfortable position as you walk away from them to take care of your. I'm having an issue with the.
Okay, and you're right, and I didn't cover that. You're right. So it's not a big deal for the test. It's not a graded checkpoint. But how do we do that, right? We have dirty gloves on. How do we get our patient from this position back onto their back and in the middle of the bed? I just showed you how, because I'm so used to doing it this way. Okay, so what's covering her?
I'm assuming the privacy blanket.
Right. I'm talking about right now, what's covering her? Privacy blanket, right? Just like we would have in a clinical setting. So we're going to ask our patient, come back onto your back for me and scoot to the middle of the bed. The only part, I've got dirty gloves on. The only part I'm touching is the blanket. That's right. I'm not touching her. So that blanket actually becomes a barrier. Now, at the end of the skill, so now some of you are like, well, wait a minute, I got to touch that thing without gloves now. Hold up. Hold up. Okay, so when I take, and again, this isn't graded on, the test isn't going to have you thinking this deep. You're thinking way deeper than the test is going to give you credit for. But I know I've touched the outside of this blanket with my dirty gloves. I know it's not clean. So when I'm ready to remove the blanket and pull the sheet up, I don't touch the top of the blanket. You're going to see this in the video as well. I always go under the blanket. I know the top is contaminated. So I will roll it up like this, pull the sheet up, or go underneath it on the sides. But I never touch the top of the blanket after my gloves come off. So it's a way of thinking about your blanket. The top is okay to soil. The bottom, you can remove the blanket by using the bottom of it. Okay. But again, the test isn't asking you for that level of knowledge. As long as you're not touching this sheet that's going to go right up next to their face with dirty gloves, that's all they care about. However else you do it is fine with them. Good? Guys, the test is not nearly as difficult, specific, nitpicky as students think it is. It's not what they're trying to do. All right, Jake, can you play Peri-Care, please? Jake is also going to be passing some things out. We're going to get to Hello, Miss Jones. My name is Patty. I'm your CNA today. How are you? Wonderful. I need to perform Peri-Care. Is that okay? I'm going to close your curtain, wash my hands, get my supplies. I'll be right back. After washing my hands, I'll get my clean supplies. We're going to place the supplies on an overbed table, and we'll start with a barrier on the table, making sure that the absorbent side is facing up to catch any water spills. This gives us a clean place to put our clean supplies. For this skill, we're going to need 2 chucks. We'll need a towel, 4 washcloths, 1, 2, 3, 4, and a privacy blanket. We'll go to the patient area. And now I'm going to get a basin and soap. We'll place this on the overbed table. And I need a set of gloves. Now I'll go fill the basin. Miss Jones, I'm going to go get some water. I'll be right back. To fill the basin, I'm going to use a paper towel to turn the faucet on because my hands are clean. I'll use my wrist to feel the water temperature. It should feel warm, not hot, not cold, just warm. And we'll fill the basin about a quarter of the way full. Mrs. Jones, would you like to check the water temperature? It's good? Wonderful. I'm going to set this on the barrier. And this is a privacy blanket. This is going to keep you warm and protect your privacy while we do this skill. I'm just going to stretch it out over your sheet. And then I'll pull the sheet down underneath the privacy blanket. And we're going to pull the sheet down to about your knees. Now, I'm going to prepare my chucks. I'll unfold them, hold them up lengthwise, and I'm going to roll it toward me. Clean rolls toward me. All the way to the end. I'll put this on the barrier and do the same with the second. I'm going to open it up. Hold it up lengthwise with the absorbent side facing me and roll it all the way to the end. Clean rolls toward me.
We'll set that on the barrier as well. Now I can put my gloves on. I'm going to place the washcloth in the basin to warm. I'll take one of the chucks that's rolled. I'm going to lay it up next to the patient under the soiled chucks. And Miss Jones, if I can have you scoot toward me, please. And we're going to roll up on your right side so I can change the chucks under you. I'll help you roll. Okay, now that you're on your side, I'm going to take the soiled chucks and roll it in. Clean rolls toward me, dirty rolls away. I want to roll it so that the absorbent side is on the inside and the waterproof side is facing up. I'm only going to touch the waterproof side, and I'm going to tuck it underneath the patient's hip. I'll unroll the clean chucks and tuck it underneath the patient's bottom area, under the dirty. Okay, Miss Jones, come on back. Thank you. And if you can scoot to the middle of the bed. Thank you. I'm going to go around to the other side. Go ahead and scoot toward me. Thank you. And roll up on your left side. 1, 2, 3. And I will remove that chucks, the soiled one, and smooth out the clean. We'll fold this up and we're going to throw this directly into the trash can. Okay, Miss Jones, can you scoot back to the center of the bed, please? Thank you. I'm going to expose you now. I'll make this as brief as possible. Please let me know if you're uncomfortable in any way. I'm going to roll the gown inside the privacy blanket, and this will expose the peri area. And then I'm going to use a towel over the upper thighs to keep all of that area dry. Now we're ready to clean. I'll take the first washcloth, wring it out, and soap 5 corners. We're going to use the leaves method, meaning the free ends are at the top of the diamond shape. I'll spray the first leaf, fold it over, spray the second leaf, fold it over, spray the third leaf, fold it over, spray the fourth leaf, fold it over, and the back. I'll set that aside. Now I'm going to clean the peri area. I'll hold the washcloth in my hand in a diamond shape, tucking in the 2 side corners, making sure I have control over the leaves and they're at the top so that we can minimize cross-contamination. Okay, Miss Jones, I'm going to start cleaning you now. I have to hold you open just a little bit, but let me know if it gets uncomfortable. So I'll take the heel of my hand at the top of the peri area, retract slightly, and spread her open a little bit. And I'm going to clean right down the inside middle, top to bottom, one direction only. Once I reach the bottom, we'll move away and fold that leaf over. I'm going to clean the outside peri area, top to bottom. Fold that leaf over. The other side, top to bottom, making sure I don't ever move back up. Fold that leaf over. The fourth leaf will go right down that skin fold, the crease between the thigh and the groin. We'll fold that over, and then we'll clean this skin fold, top to bottom, and we'll set that aside. Whatever we wash, we rinse. So I'll wring out my washcloth using that same leaves method, tucking in the 2 side corners. I'm going to retract the labia and clean top to bottom. Down the center, fold that leaf over. The second leaf will clean the outside of the peri area, top to bottom. And then we're going to fold that leaf over. The third leaf will clean the outside of the peri area on this side, top to bottom. I'll fold that leaf over. The fourth leaf will clean the crease, top to bottom. I'll fold that leaf over, and then we're going to clean this crease, top to bottom. And now we'll dry. Okay, Miss Jones, I'm just going to unroll your privacy blanket, putting the gown back over your legs, and I'm going to ask you to scoot toward me and roll you on your side so I can clean your backside. 1, 2, 3, and we're going to roll up. 1, 2, 3. We'll expose your backside, and the evaluator will hold the mannequin in place for this process. So now I can clean the backside. I'm going to wring the washcloth out. And this time, we're going to soap 4 leaves. So 1, we'll fold that over. 2, fold that over. 3, fold that over. 4, set the soap aside. I'm going to start at the anal opening and move up the crease. Just like that. We'll fold that leaf over. I'm going to clean 1 buttocks. We're going to fold that leaf over, clean the other buttocks. We'll fold that leaf over, and then once more up the crease. We'll set this washcloth aside. Whatever we wash, we rinse. So I'll wring that washcloth out really well. I'm going to hold it in that leaves shape. I'm going to rinse right up the center crease. Fold that leaf over. We'll rinse 1 buttocks. Fold that leaf over. Rinse the other buttocks. Fold that leaf over, and then once more up the center crease. Now we'll dry those areas. So starting at the anal opening, we'll dry all of those areas. We'll set that aside. Now I'm going to take the new chucks, place it under the one that's on the bed, and we're going to roll this one toward the patient and tuck it under her hip, and unroll the new one and tuck it under the soil. Okay, Ms. Jones, come on back onto your back, please. Thank you, and then scoot to the middle, please. And I'm going to go around and remove that soiled chucks. Go ahead and scoot toward me. And then we're going to roll up on your side, 1, 2, 3. So I'll remove that soiled chucks and smooth out the new one. Come on back onto your back and then scoot to the middle of the bed, please. Thank you. This will be thrown away. Okay, Ms. Jones, you're covered. You're in the center of the bed. I'm going to go put your dirty linens away and clean the basin. I'll be right back. These items will go in dirty linen hamper. And I'll clean the basin the same way we clean all basins. We're going to dispose of the water into the sink. Rinse the basin. Dispose of the rinse water into the sink. Set it down. Disinfect it per facility policy. Use a paper towel to pick it up. Paper towel to dry the inside. Throw that away. Paper towel to dry the outside. Throw that away. And 1 for the drawer. On the way, we'll pick up the soap. Place it in the basin. Use the paper towel to open the middle drawer. Pick up the lotion and put it in the basin. And then store the basin in the drawer. We'll close it with a paper towel and then throw those paper towels away. We'll dispose of the barrier that's on the table. And then remove my gloves. Okay, Ms. Jones, I'm going to pull your privacy blanket up and put your sheet back in place. We'll make sure that the patient is covered and that we roll the privacy blanket up in a ball as we remove it from the patient. I want to adjust the sheet for neatness and appearance. And I'm going to go place this in dirty linen. Okay, Ms. Jones, are you comfortable? Is there anything else I can get for you while I'm here? Would you like a magazine? No? Okay, your environment is clean. Here's your call light. If you need anything at all, just press that red button and somebody will be happy to help you. Your bed is in the low position. I'm going to open your privacy curtain and go wash my hands. We'll return this table to storage before we go, leaving our area clean. After washing my hands, I'll review the care plan, make any corrections, and tell the evaluator my skill is done.
Thank you. Appreciate it. All right, so let's get into, anybody have any questions on Peri-Care before I go? Okay. Let's get into blood pressure. Ooh. Moving right along. Blood pressure is not tested on the state exam. You do not have to take a blood pressure. You will never be asked to take a blood pressure, not a manual one, not an automated one, not on the state exam. There's a lot of settings that are going to restrict CNAs from performing blood pressures. So you would want to check with your policy and procedure wherever you go to work to find out whether you're allowed to take blood pressures, and if so, what kind of blood pressures you are allowed to take. Okay. This is really going to be affected by your policies and procedures. And that's because this is a skill that we make medication decisions off of. And it's just not something that is done correctly by most people. So we're treating patients off of incorrect information, and that can cause serious health consequences. So the instructions for blood pressure are on page 56. But essentially, and we saw this already with pulse, when your heart squeezes, it pushes out a wave of blood, and that wave pushes the one in front of it, and that wave pushes the one in front of it. You guys remember that? With pulse, we just put our fingers there and counted the waves, what we felt under our fingers. With blood pressure, it's the same heart, the same waves, the same blood pressure, or the same blood vessels, all of that's the same. But instead of counting the waves, this time, I want to know how much pressure is inside this artery when a wave is going through, and how much pressure is inside the artery when the wave is at rest, when the heart's at rest. So remember that hose we talked about on the faucet? You turn the faucet all the way on, the hose expands, gets big, more pressure. The hose is off, or the water faucet goes off, the hose shrinks, less pressure. That's what's happening here. We have pressure, more pressure, less pressure, more pressure, less pressure, more pressure. And all I want to know is, what are those numbers? When there's more pressure, how much? When there's less pressure, how much? That's what I want to know here. And we have a tool that will let us measure that. So when we use a sphygmomanometer, which is a blood pressure gauge, and a blood pressure cuff, we're going to use air in the cuff to squeeze inward on the arm, and that's going to crimp off the blood vessel, the artery. We're crimping it off. And then we're slowly going to open it, so it slowly expands, slowly expands, slowly expands, and at some point it's expanded enough that a wave can push its way through. When a wave pushes its way through, we hear that wave hit the top of the artery, because the artery is still real small, and it makes a thunk sound. Eventually, as we're letting the air out and the blood vessel gets bigger and bigger and bigger, eventually the waves are just able to go through. They're no longer hitting the top of that vessel, and the sounds stop. So these two features, when we hear the first thump and when we stop hearing thumps, makes up our blood pressure. So when we hear the first thump, that is our systolic or top number. That's when the heart is contracting, systolic. When we stop hearing thumps, that's the diastolic pressure, or how much pressure is inside the vessel when the heart is at rest. diastolic, bottom number. So we have to have some normal values, because if there's no normal values, we don't know what's abnormal. We have to know normal first. So normal for the top number, when the heart is squeezing, normal pressure is between 100 and 119 on the gauge. That's what we're hoping for. Between 100 and 119. That's what we want to see. It's probably not what we're going to see, because most people in America have higher blood pressure, but that's what we're hoping to see. Normal on the bottom is between 60 and 79. So normal diastolic, bottom number is between 60 and 79. That's what we hope to see. It's probably not what you're going to see, but that's what we hope to see. These are normal. What would we do with anything that is not in those ranges? Tell the nurse. So how do we get those numbers? We use a gauge. This gauge is called a sphygmomanometer. And when we inflate our cuff, this needle is going to go up as we inflate the cuff. As a CNA, we're going to stop somewhere right here between 160 and 180. We don't go past 180. That hurts. Remember, CNAs do normal? Who does not normal? Nurse. This is not our domain over here. We inflate up to somewhere between 160 and 180. And then we slowly deflate. And as we slowly deflate, that needle is going to come down at about that rate. Slowly, it's going to come down. Now, we're not going to hear anything. It's going to be quiet. Quiet, 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 quiet. You're not going to hear anything. Remember, our normal values were between 100 and 119. Right here. This is where this little tiny area right here, just this little tiny section, is where we should hear the first thump if we're normal. That means, remember, we inflated way up to here. So all of this is quiet, 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 still quiet, still nothing happening. Quiet, 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 thump. There's a whole lot of quiet there. Don't give up. Keep listening. Where you hear the first thump, where the needle is pointing, is your top number of your blood pressure. You're going to hear more thumps. Thump, thump, thump. We don't care about those. Thump, thump, thump. Don't care. Thump, thump. We don't care. What we're listening for now is our last clear thump. But the problem is the last one doesn't tell you it's the last one. It doesn't say, get ready, get set, here I come, ta-da. It doesn't do that. It just goes thump, thump, thump. Oh, where was the last one? So you have to pay attention to each one because it could be the last one. Make sense? Okay. So the last clear thump that you hear, where the needle is, when you heard that last clear thump, that's your bottom number. And then you deflate all the way back to 0. So you inflate, you deflate slowly, you listen for the first thump, top number, last thump, bottom number. That's all a blood pressure is. Super easy in theory. Problem is that it takes a lot of coordination because your hand has to inflate the cuff and work the dial to deflate the cuff so that needle stays nice and steady and it doesn't go woo. It's got to stay nice and slow and steady. So your hands are involved. Your eyes are involved because they're watching that needle and figuring out where that needle is. Your ears are involved because they're listening for those thumps and your brain has to put all of that together. So in theory, we inflate, we deflate, we listen for the first and listen for the last. Easy. In practice, a little more complex because you got to practice this. Now there's 2 pieces of equipment we're going to use to get this reading. The first is your stethoscope. So go ahead and open your kits. And let's talk about stethoscope.
This is the head of the stethoscope. It usually has a very large diaphragm. On the other side of it may be a smaller diaphragm or a bell, which is like a little cup-shaped thing, or you may not have anything at all. All of them are okay. What we want to focus on is the large diaphragm. That's what we're going to use. We are listening for a wave of blood hitting the top of an artery buried under muscle, fat, and tissue. It's not a big sound. You need a big microphone. This is a microphone. That's all it is. Okay. So don't worry about what's on this side. We want this side. But the problem is that if you have two sides, that means we have to tell the stethoscope which side we want to listen to. This whole thing turns. The whole head turns. You see that? So on your stethoscope, there's probably a little dot or a flat area. Look for a dot or a flat area, and you want to make sure that your large diaphragm is facing the same direction as your dot. Now, this side is on. If you have it the other way, this side is on, and the heart part we're listening to is off. Okay, good, good. All right, so now we're going to talk about the ear tips. Ear tips are usually put in the wrong way. You don't want them to be straight. They need to be slightly curved. Do you see how these are just slightly curved to the front? You can hold the chin strap here area. If you hold this area, you can actually turn these to adjust them. You don't want them straight in. You want them at a slight angle. Nope. We're going to talk about that in a minute. Doesn't matter. Right now, they just need to be at a slight angle pointing one direction. Okay, both of them pointing one direction. Not too much. You don't want them too much, just a very slight angle. And then when we put them in, right, you can put them in this way or you can put them in this way. Which way do we go? They always face away from you because in our world, it's always about the patient. So you want these facing away from you, and you're going to put them in your ears and very gently tap your diaphragm. Put them in your ears and then tap your diaphragm. Jake, you need this?
Sorry?
Do you need this?
Yes.
574.
Thank you.
You got it off my phone?
Yes.
Okay. All right. So I want you to take them out, flip them over. Just flip the whole thing over, put them in backwards, and then tap that diaphragm again. Take them out, flip them around, put them back in the right way. They're probably a whole lot more comfortable. And tap again. The reason that most people cannot hear a blood pressure is because they have their ear tips in the wrong way. Good? Good? Yep. Yeah, and we used to, when I had the retail store, we used to sell Littmann stethoscopes, which are the real high-end ones. And people would bring them back and say, it's broken, it doesn't work. And you would flip over the diaphragm and turn it around and hand it to them. And they go, oh, you fixed it. So it's very, very common. This is a very, very common issue. And I don't know why our brains always put the stethoscope in the wrong way. But if I just leave a stethoscope on the table, you will always put it in the wrong way unless you're instructed otherwise. I don't know why our brains do that. That's like a psychology thing that I'd love to study. But I have to bring that to your attention. They face away from you. Okay. Now, let's talk about the blood pressure cuff itself. Now, these are one size fits most, not one size fits all. So on the cuff itself, if you have a professional cuff, on one edge, one of the shorter edges, you're going to see a white stripe. This white stripe allows you to measure this against your patient's arm. So if I'm not sure if this patient is going to, or if this cuff is going to fit my patient, I would take this white stripe and I'm going to put it underneath the patient's arm about an inch above the elbow, just like this. Now, if I can see both of the corners, it fits my patient. It's okay. If I can't see either of the corners looking straight down on it, it's not going to fit my patient. It's too small. If it wraps more than halfway around the arm, it's too big. So this stripe has to fit between 1/2 and 1/3 the circumference of the arm for it to work for your patient. If you use the wrong size cuff, it affects your reading. It can make the blood pressure cuff look, or the blood pressure reading look higher than it actually is, or lower. All right, so now let's learn how to read the dial. So remember that we inflated up to somewhere between 160 and 180. We deflated slowly. We listened for the first and last thump. That's all fine and good, but we got to know what number that needle is pointing at. So these are measured and marked in 20s, 20, 40, 60, 80, 100, 120, 140, 160, 180, 200. The big lines in between are your 10s. Please don't inflate your cuffs right now until they're wrapped around something you can actually knock off the calibration of the dial. So don't inflate your cuffs. They've got to be wrapped around something. They have to exert pressure to keep calibration, okay? So your bigger marks in between are going to be your 10. So this is 20, that's 30, even though it's not marked. There's 40, that one's 50, 60, 70, 80, 90. The little teeny tiny marks in between are 2s. So if this is the line for 140, this is 142, 144, 146, 148, and then the line for 150. Everything is an even number on this dial. Everything is an even number. Please do not give me odd numbers. I know you're guessing. Okay. So in order to do this, we're going to use the bulb and valve assembly to inflate and deflate the cuff. Jake, do we have one more can by any chance? Thank you. Okay. So let me show you how to inflate and deflate the cuff. Ugh. All right. When we have a cuff, you want to hold the bulb and valve assembly in your dominant hand. So if you're right-handed, it should be in your right hand. If you're left-handed, you should hold it in your left hand. It needs to be in your dominant hand. But I'll show you how to put them on your cans in a minute. But you need to hold this in your dominant hand. And you want to hold it so that the tube faces up. Not like this. This is not correct. The tube faces up. And when you're holding it, you've got to be able to hold that little silver dial between your thumb and your finger. And you're going to hold on to that thing like it's a life preserver. You're going to close it, not tighten it, just close it, just until it stops. You're going to pump the ball up, and then you're going to hold that silver dial, and ever so slowly, you're going to turn it to the left, lefty-loosey, to let the air out. And these are little itty-bitty, teeny tiny motions. I mean, tiny, tiny, tiny hair motions, not big motions at all. But you want to keep your fingers on that dial as you're doing it, because if you let go, when you try to grab it again, it's going to move it, and then your needle's going to go woo, and you're not going to get the reading. Okay, so we hold this dial in between our thumb and index finger. We don't let it go once we start deflating. Good. All right. So if you take your cuff, and lay it down on your table, and you place your can on your cuff and wrap the edge around. You want to keep rolling it until it fastens snugly against the can. Yeah, wrap it around. Keep rolling, keep rolling, keep rolling, keep rolling. There you go. There you go. Okay. So, okay. So yours are home cuffs. They're a little bit different. So these are a little bit different. You don't want to separate this. We're going to put it on here. And then we're going to tighten it this way. There you go. So this dial is what's going to allow us to put air into the cuff and allow us to control the air that comes out of the cuff, which will control that needle, how fast it comes down. We're going to turn that little silver dial to the right just until it stops. So if you're holding this, that silver dial should be facing you. You want to turn that silver dial to the right just until it stops. And you want to pump the ball to put air in until that needle gets down to somewhere between, or gets up to somewhere between 160 and 180. Now, the air will probably start to leak out a little bit because there's pressure against it. That's fine. You're going to hold that silver dial in your hand, in between your fingers, and you're going to slowly turn it to the left to let the air out. Slowly turn it to the left to let the air out. Now, it should be a very slow motion. All right, Jake, you're going to zoom. Zoom. So this is what, that's good. Let me get in here. Okay. So this is what it should look like. I'm going to turn my dial to the left, or I'm sorry, to the right. I'm going to pump it just until I get up to somewhere between 160 and 180. And I'm going to hold that little silver dial between my thumb and index finger, and I'm going to turn it ever so slightly to the left. Do you see that rate of my needle? That is what your needle should look like. All the way down. Now, I'm having to open it a little more and just a hair more because it'll slow down. So a little more, 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 and then down to 0. If your needle is not going up and staying up, it means that you've turned your valve the wrong way. That little silver valve, turn it the other way. Okay, go ahead and give it a try. Inflate and deflate a couple times.
I believe this was is decalibrated or uncalibrated, whatever, because of the initially it was not at 0, it was like right next to the 0.
That's okay, as long as it's there's a little bit of residual air in there. So yeah, it's fine.
All right, cool.
It's fine. All right, so I'm going to show you what's happening inside. I've only got like 2 minutes left with you. I'm going to show you what's happening on the inside of the body. As we inflate that cuff, it's going to press against, it's going to put pressure against the muscles, which is going to squeeze that artery that's going through your arm. And what we want to do is basically close that artery off. As we open the dial, so this is what's going to happen when we get up to somewhere between 160 and 180. As we open up that valve, the heart is still beating. It's still sending out waves. We're just not letting them through. We put up a toll booth here. As we start to let the air out using this valve, and that needle starts to come down, we are going to take a stethoscope. We're relieving the pressure against that artery. We are going to take a stethoscope and listen over the artery. And what we want to hear is a wave of blood hitting the top of the artery, and it's going to make a thunk sound. We're listening for the first thunk sound we hear. When we hear a thunk sound, it's called a Korotkov sound. That's its technical name. When we hear that, wherever that needle is, whatever number it's pointing to is our top number. Now you're going to see that needle kind of jump, okay? It kind of ticks. Those ticks are not the blood pressure. Those ticks have nothing to do with the blood pressure. It's another wave joining the party that was produced by the heart. It's not pressure. We need the pressure. So the ticks don't count. It's what we hear. Where did we hear the thumps? So this needle is pointing at, this is 100, this 102, 104, 106, 108. That is our top number. We're going to keep listening. We're going to hear more thumps. We don't care about those thumps. We're hearing more thumps because the first one was able to hit the top of the artery. Others can. What we're listening for now is the last clear thump. So where was the last clear thump that you heard? Where the needle was on the dial, when you heard the last clear thump is your bottom number. You're going to keep listening for a little bit because it may not truly be the last one. You got to make sure it is the last one. So we're going to keep listening. And as long as our top number is in this range and our bottom number is in this range, that person has normal blood pressure. If either one of those are out of range, you have to report it. You're going to get that needle all the way to 0 before you take your stethoscope out of your ears and your cuff off your patient. Okay, good. So where we heard the first thump here was 108. Where we heard the last thump here was 62. So our patient's blood pressure is 108 over 62. Good? All right, if you go to page 57, there's a whole lesson here I need you to read because we're not going to have time to get into it. But this activity will help you put into practice what you just learned. Okay? And then you can go home and practice on the unsuspecting public at home.
Just don't do it too many times in a row.
Yeah, twice on one arm. That's it. That's all you're allowed to do. Twice on one arm, then move to another arm, then move to another person. You're compressing an artery. We're stopping blood flow. That's not a good thing. Okay. If you get an abnormal reading, it's probably you, not them. Don't call 911. And you probably want to get in the habit of asking somebody, which arm can I use? Most people will say, I don't care, pick one. And that's fine. You got 2 arms, use them. But there are some people who will say, you cannot take a blood pressure in my left arm, and you're going to believe them, and you're going to stay away from that arm. There's a lot of reasons why we can't take blood pressure on one side or another. Out there, you're going to look at your care plan. When you're practicing on family, you're going to listen to them. Good? Questions? All right, Jake's going to pass out the review sheets for today, and we are now finally all caught up. So,
Monday, we have our final 3 skills. We've only got 3 to go. Monday. You will have some practice time in class on Monday. Wednesday is graduation. There's nothing you need to do for graduation. I handle it all. But if you want to bring cupcakes or cookies or something like that to celebrate it, you're free to do so. I'm going to be giving out folders with next steps. We're going to talk about employment, finding a job, how to ace your interviews, all of that kind of stuff. But we also need to talk about renewal and continuing education. So we got a lot to cover on Wednesday, but we will have practice time on Wednesday as well. Have a fantastic weekend. Make sure you do something fun. And I will see you in class on Monday. Thank you guys so much. Those of you who joined us virtually, thank you for sticking around. And remember, Monday, we have class 7, last skills. Tuesday is our game show. So mark your calendars. Till next time, happy caregiving. Bye.